टिल्ट हुआ है इसमें बोलो हेलो हेलो
इसको लगा
देखिए सेट है यहाँ
ये लगा हुआ है वो लगा हुआ है इसको
ठीक आगे सेट
अच्छा ये देखिए वो लगा हुआ है क्या ये वाली केबल हाँ ये वाली केबल ये देखिए नहीं ये नहीं लगी हुई नहीं होगा कोई
अस्सलाम वालेकुम, मैं डॉक्टर मरियम। नहीं आ रही? अभी बोलूं? अब
यही
सही ये गिर जाएगा, पता लगे मैं बोल रही हूँ और ये गिर जाए।
आपके
कोई बात नहीं, बोलो। अस्सलाम वालेकुम and a very good morning. Having an oral.
अभी एक आप इधर ये बैकड्रॉप बहुत अच्छा लग रहा है।
तो बहुत प्यारा,
आजकल ये
ये
मस्जिद
बड़ा, ये मस्जिद बहुत प्यारी है ये। सर ये है भी बड़ी प्यारी, आपने देखी है
हाँ,
कभी
ये
जाके?
देख के लग गया।
बड़ी हसीन है।
बच्चों को
इसके
ले।
सामने बिल्कुल वो है फोर्ट जो है, लाहौर फोर्ट। उधर भी गए थे फिर साथ, क्योंकि साथ साइड बाय साइड है ना। वैसे तो यहीं पे थक जाता है बंदा इतना। Okay. Assalamu alaikum and a very good morning. Okay. After. Assalamu alaikum, and a very good morning. After having the oral and poster session, I extend my very warm welcome to everyone at the last day of third International Conference of Rehabilitation. I'm Dr. Mariam Shabir, moderator for this plenary session, getting ahead to the next session, fourth, plenary 3. The session will be chaired by Honorable Professor Dr. Ashfaq Ahmed and co-chaired by Dr. Muhammad Nazim Farooq. We are honored to have their company here. Now I will introduce my chairperson, Professor Dr. Ashfaq Ahmed. Professor Dr. Ashfaq Ahmed is currently working as an Associate Dean, Faculty of Allied Health Sciences, Physical Therapy, as well as Head of Department, Professor, University Institute of Physical Therapy, University of Lahore, and he is also working as an head of department of Center of Research in Physical Therapy at University of Lahore. He has done his first ever physical therapy from the very qualified foreign professors. He has more than 18 years of experience, and he has 120 high impact factor articles in well-renowned national and international journals. He has established clinical and academical setups of physical therapy in well-renowned organizations and universities of Pakistan. He is the man with the vision of taking physical therapy and rehabilitation sciences at its peak. He has also worked as chairman, board of directors, Pakistan Physical Therapy Association, and is a member of National Curriculum Review Committee, Higher Education Commission, Pakistan. He also has the honor to start the first ever PhD physical therapy in Pakistan. He has certification in Annie Panman laser physical therapy from Glasgow, Scotland, UK, and Thor laser physical therapy from Edinburgh, Scotland, UK. Now, I will introduce the co-chair of this session, Professor Dr. Muhammad Nazim Farooq. Professor Dr. Muhammad Nazim Farooq is a certified spinal manual therapist. He has done his manual therapy from Oxford Brookes University in 2007. He qualified with Masters of Science in Advanced Manipulative Physiotherapy in 2009 from University of Birmingham, UK. He completed his PhD physical therapy in 2017 from the University of Lahore, Pakistan. Dr. Nazim joined Islamabad College of Physiotherapy, Margala Institute of Health Sciences, Rawalpindi in 2009 as a HOD and assistant professor. Currently, he is working as principal and dean of Islamabad College of Physiotherapy. Dr. Nazim has more than 20 publications in national and international journals. Dr. Nazim is an experienced musculoskeletal clinician and is a member of the Musculoskeletal Association of Chartered Physical Therapy, United Kingdom. Now, after the introduction of my worthy chair and co-chair, I would like to introduce the first keynote speaker of this session, Professor Dr. Paul Hodges. Professor Dr. Paul Hodges is a senior research fellow and director of the National Health and Medical Research Council Center for the Clinical Research Excellence in Spinal Pain and Injury and Health at the University of Queensland, Australia. He is leader and chief investigator on an NHMRC program grant and a fellow of Australian Academy of Science and Australian College of Physiotherapists, and he has honored to be a member of the Australian Physical Therapy Association. Professor Dr. Paul is recognized for his expertise in movement control, pain, and rehabilitation, and has received numerous national and international awards. He also has received national community-based leadership awards, including the Young Australian of the Year Award in Science and Technology 19 and 97, Future Summit Australian Leadership Award in 2010, and Emerging Leader Award in 2009. Professor Paul has working as president of International Society for Electrophysiology and Kinesiology and has been the chair and the co-chair for the several major international conferences. He has led major international consortia to bring together leaders from the multiple disciplines to understand the pain. The topic for the first keynote speaker of this plenary session is motor control and musculoskeletal pain, tailoring treatment to individuals. And to present that, please welcome to Professor Dr. Paul Hodges. Thank you so much.
It's a great pleasure to There is no question that movement and stiffness of the spine depend on muscle and neuromuscular control. There is no question that these can be different in people with low back pain. But what is questionable is whether this is necessary or relevant for every person who has low back pain. And really what I'd like to talk about today is how do you decide who it is that you should treat with a motor control approach and what other approaches are available. So one thing that we realise is that all musculoskeletal pain, and what we very well know for back pain, is that it's multifactorial. And what this tells us is that there are multiple factors that could be present within each individual patient across the domains of biology, psychology, and social factors. And all of these factors could influence the presentation that a person has. And we need to consider that if we're going to design interventions to manage a person with low back pain. We need to decide what are the targets that we should address with our patient. So in terms of low back pain, we know that exercise is one of the most effective treatments for chronic low back pain. It's included in clinical practice guidelines internationally, but there's little guidance about the type of exercise. Now, what I've been working on for many years is motor control exercise. So motor control training is amongst the most researched approaches for low back pain. It's been included in 160 randomized controlled trials and 12 systematic reviews. And what I'd like to do today is to really answer these two questions, and that is, well, what is it and who does it work for? But to do that, I'm going to address 4 key topics. So the first thing is to consider, well, what is optimal control of the lumbopelvic region? And considering some principles that we can apply to other regions of the body. One key feature, which is, I think, really critical in making decisions, is to understand pain neurobiology and how we might use that information to assist our clinical decisions. And then to consider, well, how can we apply this information in clinical practice? So I want to give you some clinical tips about how you might select patients and how you might design an intervention. And then finally, to consider, well, what is the evidence? So what is optimal lumbopelvic control? And what I'd like to suggest is that there are 5 key principles that help us understand optimal lumbopelvic control. The first thing is that optimal lumbopelvic control involves a balance between movement and stiffness. And what do I mean by that? I mean that in order to have ideal control, it doesn't mean that we need to have a spine or a body segment that is stiff. What it needs is we need some movement and we need some stiffness. Now, if we look at the fellow on the left who's attempting to run, you can see that he's achieving the goal of keeping his spine upright. He's keeping it very rigid and he's holding it stiff. So this is a person whose strategy for control of the spine is to prevent movement. Now, what I'd like to suggest is that that is not ideal. And if you look at the fellow who's running on the right, you can see that he's not keeping his spine stiff. He's actually using movement. And he's using movement for many reasons. He's using movement as a shock absorber. So every time his foot hits the ground, he gets a little bit of movement to absorb some of the impact. He's using movement to transfer the loads through his body. He's using movement for the function. So the function of running involves extending your leg out forwards. It involves getting counter rotation through the pelvis and shoulders, and that all involves movement. And it also means that he's not just loading one region of the body, he's distributing that load around the body. So what I'd like to suggest is that optimal control is not about holding yourself rigid or stiff. It's actually about having this balance between movement and stiffness. And a thing that I'll mention a little bit later is that everybody needs to be able to adjust that depending on the function. For example, the person on the right, the strategy they're using there is ideal for running. The strategy the person on the left is using is not ideal for running, but it might be appropriate for lifting a box. So if you're lifting up 100 kilograms from the floor, it may be appropriate to keep your spine rigid. So you might need to adjust the balance between how stiff you are and how mobile you are based on the task that you're performing. And one thing that's critical to consider is that you can be too stiff and you can also move too much. So optimal control is about finding that balance. The next principle of motor control, of optimal control of body regions, is that all muscles are important. Now, many regions of the body, including the back, have a deeper layer of muscles like the transversus abdominis, the multifidi, which are very close to the lumbar segments, which are important for control of the spine in terms of balancing movement and stiffness. But it's also critical to have every other layer of muscle as well, and they all perform some slightly different functions. So one way to think about this is if we think about the spine as this unstable stack of blocks, if we only had muscles that went from the top to the bottom, like the guy ropes of a flagpole, those muscles would be able to keep you upright, but they wouldn't be able to control what happened in individual segments. So instead, if we have a system of muscles that are deep, that attach to individual segments, that can control the motion and stiffness at individual segments, and then over the top of that, we have long muscles which keep us upright, then those two systems can work together for ideal control. One system for this fine regulation of intervertebral motion or motion of any joint. And then there's larger muscles that keep you upright and generate torques to move you. So that's the second principle. All muscles are important. The third thing is that it's not just about the muscles themselves, but their connective tissues. So things like the thoracolumbar fascia. All of these fascial structures provide the attachments of the muscles to the segments, and regulation of the tension in those fascias is going to be important. And also for the spine, the pressure in the abdomen is going to be critical. Again, we need to remember that it's a balance. You can have too much fascial stiffness. You can have too much intra-abdominal pressure or too little. It's about finding a balance. So the third principle is about this need to control fascial tensions and pressures. And for the spine, that's really important because that means we need to consider how we regulate the pressure and fascial tension, and that needs to include activation of the diaphragm, activation of the pelvic floor. So the floor and the roof of this abdominal canister need to be controlled as part of the spine control mechanism. So you can imagine then that people with back pain, you might need to consider breathing, you might need to consider continence and pelvic floor functions. The fourth basic principle of optimal control is that we need to consider that there are strategies, different neural strategies that can be used to control the spine. And I like to think about three basic strategies. One is predictive control, one is reactive, and one is ongoing tonic activity. What do I mean by that? So predictive control is feed-forward control. So when you know that a force is going to be applied to the body, you can prepare for that in advance. And we did studies many years ago that showed that when you move an arm, your brain knows that that's going to challenge the spine. So it activates muscles in advance. And one of the things that it does is activate deep muscles and then the more superficial layers of trunk muscle. So predictive. We also need to think about reactive control. And so you can't predict everything. And if you are standing on a bus and the bus takes off, or if you don't know that a force is going to be applied to the body, you need to be able to react. And there is clearly fast, simple reflexes. There's also more complex whole body responses to react. And then in addition to that, you can't predict everything and reactions take time. So one thing we need to consider is that sometimes we would also benefit from this ongoing level of tonic activity of muscles that provides you with this underlying control that's there ready just in case you get disturbed. And this example here, you can see a person running and you can see that the activation of transversus abdominis is occurring tonically throughout the walking cycle or the running cycle. So that suggests that this person is maintaining a little bit of control just in case they get disturbed. So those three strategies are used for controlling providing optimal control for any joint in the body. And when we think clinically, we need to think about preparing people to prepare, to react, and to maintain tonic activity as required for the task. And the fifth thing is that we need to consider this spectrum from dynamic to static. And what I mean by that is that some situations, so some tasks like lifting, pushing, pulling, we might want to have a strategy that allows us to be more static, so stiffening the segment for control. But many other functions we want to be more dynamic, so using movement for all of those benefits of shock absorption, for load sharing, etc. So how does all this change when people have pain? And what I'd like to think about is that we need to consider the motor system from different perspectives. So we need to think about posture. Now, posture is something that people have talked about for many years with potential relevance to back pain. And what I'd like to suggest is that there is not a posture which is negative, but there can be a range of postures that are not ideal for a particular person's context. For example, there may be someone who has a job that involves sitting all day, and they may use a spinal posture that allows creep over time and increased load on tissues. There may be a person whose strategy instead involves actively holding themselves erect and excessively putting compressive load on their spine, or a person who has a sway back. So what I'd like to suggest is that there's not one posture which is potentially negative, but in each individual there may be features that are suboptimal for the loading of their tissues. We also need to remember that people in the community who have these postures don't necessarily have back pain. And that might be because they don't have sufficient exposure. They might not actually use that posture very frequently. Or they may have a situation where their body is adapted to that in a more optimal way. So we can't assume that these postures are problematic. But if we look at a patient and we identify these features and they're relevant for their pain provocation, then perhaps they are. Same thing applies to movement. There are many ways that movement might change. So you might move too little, you might move too much, or you might excessively use one segment rather than another. And this slide at the bottom, which comes from Shirley Salmon's group, shows that when the person is rotating their hip, they're using their pelvis and spine instead of the hip. So maybe the ways that people move could be loading tissues inappropriately. And for individual patients, there may be relevant strategies. What about muscle? Well, muscle activation can change in many ways, and we've done lots of research over many years that show that the control of muscles can be compromised. So too little activation that's too late. There may be structural changes in the muscle, so atrophy, fatty infiltration, fibrosis. So what that would suggest is that if the muscles are delayed, if there's fibrosis, if they're not tonically active, what that may mean is that you allow movement to occur excessively. There may be poor control of intervertebral motion, for example. But at the other end of the spectrum, many people change the activation of muscles by using muscles too much. So too early, too long, or too much activation. So that co-contraction of stiffening, reducing the shock absorption, increasing the compressive load. So in many people, what you might find is this poor balance between muscle activity. Some elements might be working too little, some might be working too much, and both of those can be a problem. So I don't think our strategy in managing patients is always about making them use muscles more. It may in fact involve suggesting or trying to train them to use muscles less. And we need to assess that and identify, well, what changes are necessary to optimize the loading. There are some other things to consider. For example, sensory function. So we know that many people with pain in many regions of the body have poor sensory input coming from their tissues. They have poor use of that sensory information by the nervous system and a modified representation in their brain. So meaning that if you don't know where your body is, if you can't perceive how it's moving, then how can you possibly plan appropriate motor responses to control for that? We also need to think about suboptimal coordination of function. So before I mentioned that control of the diaphragm and pelvic floor is critical for being able to maintain spine control. And if you do have a breathing disorder or a pelvic floor dysfunction or a balance disorder, those factors could compromise the control of the spine. And we need to keep that in perspective, because that may be something that we need to identify and then address with treatment. So why does motor control change? How does motor control change in pain? Well, as I've said, it can change in all of these different ways. And what we need to consider is that in the individual patients that we observe, there's going to be individual variation in how their motor control is presenting, and we need to address that. Now, our assumption for the mechanism for motor control training is that if the load on the tissues is causing nociceptor discharge, which contributes to a person's pain experience. So if someone is having pain that is associated with the way they use their body, so there's a relationship between the postures that they use, the movements that they use, the muscle activation that they use, and their pain experience, then it may be helpful to change the way they move, to optimize the loading on the tissues, to be able to reduce the nociceptive discharge and its contribution to their pain. So what I'm suggesting is that there are a group of people who continue to have pain because of the way they use their body. So what I'd like to move on to then is to consider the next topic, and that is, well, how can we use the neurobiology of pain to assist in our clinical decision making? So just remember that pain is an output. So nociception is the input coming into the nervous system that tells us about threat. So something chemical, thermal, or mechanical that is affecting the tissues, and pain is our response to that. Now, in an acute situation, pain is really important because it alerts us to that threat and it motivates us to make a change. So if the nervous system perceives information that there is threat to the tissues and it's necessary to make a reaction, it will then make a response, such as getting you to walk away or lift your hand off the hot plate or something, which is going to remove that threat to the tissues, make you move differently to reduce the threat to the tissues. So pain in an acute sense makes a lot of sense. But pain is more complicated than that because it's not a simple input-output system. What comes in doesn't necessarily match what comes out. And that's because there's amplifiers. So your nervous system may have this belief that the threat to the tissues is more than it is and increase the pain experience. It may be that you are more threatened because of work-related features, because of your previous experience, because of fear, many different features. There's also physiological sensitization. So there can be amplification at different points of the nervous system that mean that a stimulus coming in can be amplified and achieve a greater pain output. So this is really important because this helps us understand some different presentations of pain. So for example, there is one group of pain patients whose pain is primarily maintained by nociception. So this is presumed to be associated with actual or threatened damage to non-neural tissues. So someone where their movement is consistently related to their pain response. Another type of pain presentation is nociplastic, and this is where there is altered nociception despite no threat or damage to the tissues. And it's caused by either activation of or amplification at any level of the nervous system. So there can be sensitization within the spinal cord, in the periphery, in the central nervous system, that all influence your perception. And this type of pain is really very much associated with the psychological features. So people who are very threatened by pain, there will be greater amplification or central sensitization. So some people's pain is maintained not because of ongoing peripheral input, but because of these sensitization mechanisms in the nervous system. And the third main category of pain is neuropathic, and that is pain that is caused directly by lesion to neural tissue, such as sciatica or peripheral nerve lesions, where there is a nerve involvement or nerve damage or dysfunction involvement in their pain experience. So what this means is that we have different types of pain presentation, and what I'd like to suggest is that in the nociceptive movement-related group, if there are features that are of the way the person uses their body that are driving that nociceptive input, then it makes sense to change that with intervention. And that's, I think, where motor control training has its biggest contribution. If someone has nociplastic pain, so this central sensitization, then I don't think changing the way they move is particularly relevant. I think for those people, it's about reducing the amplification. Exercise might be important as part of getting back to function and their cognitive behavioral exposure to normal physical activity, but it's not about changing the way they move. It's about reducing this amplification. And then in neuropathic pain, there might be some things you change about the way they move in order to reduce the loading on tissues, but these people are often also including some sensitization mechanisms that need to be considered. So putting all this together, what it suggests is that some people continue to have pain because of ongoing threat to their tissues. In that case, there is this nociceptive mechanism, suboptimal loading of their tissues, and then motor control training may be appropriate. So consider addressing the features of the way they move. So modify their posture, their movement, their muscle activation to reduce that nociceptive input and return them to a pain-free state. But then there's other people where there is no ongoing threat to the tissues, that the nociplastic mechanisms are the primary mechanisms driving their their pain experience through central sensitization. And for those people, it's not about changing the way they move, it's about modifying their cognitions, their behaviors, and that could involve graded activity, it could involve education and other approaches. So how can we put all this into practice? Well, the first thing I'd like you to consider is there's lots of discussion at the moment about should we just treat the mind when people have pain, or should we treat the body? And what I'd like to suggest is that people who have a nociplastic presentation, then treating the mind should be the priority, so education, behavioural therapy. People where tissue loading and the way they move is relevant, they should benefit from a motor control approach. So we need to identify, well, where do people lie along this spectrum? So there are some clinical features that we can use to help with this, and there's some work that we've done that we've published in Pain this year that shows that there are clinical features that can help discriminate between these different groups, and that's been informed by some work by many researchers over the last 10 to 15 years. So nociceptive pain is pain that is predictable. It increases and decreases in predictable ways with movements and postures. It's proportional and it's localized. At the nociplastic end, it's unpredictable, it's inconsistent, it's disproportionate, multiple body areas, changing body areas. Neuropathic pain has those really typical signs that you get with sciatica, so pins and needles, numbness, electric pain in dermatomal distribution. Quantitative sensory testing for people with nociceptive pain, they've usually got normal sensitivity or maybe a bit of hypersensitivity at the site of their pain. If they've got nociplastic pain, they have hyperalgesia, so they're more sensitive to pressure and temperature, both locally and at distant regions of the body. And in neuropathic pain, that can also be present. With questionnaires, people with nociceptive pain generally score low on psychological features, whereas people with nociplastic pain score high. They have high features of catastrophizing, fear avoidance, and low pain self-efficacy. Neuropathic pain, there are some questionnaires that help you identify people with neuropathic presentations. And then in terms of history, nociceptive pain is associated with having a relevant injury history or loading history. Nociplastic pain, there seems to be a mismatch between those. And in neuropathic pain, there's a history of nerve damage or dysfunction. So what I'm suggesting is that for those who have nociceptive pain, using a motor control approach is likely to be relevant. So what is motor control training? Well, motor control training aims to restore the optimal control of the spinal pelvis or other body region with attention to the way they use muscles, posture, movement, and their sensory function, with the intention to optimize the load on the structures, but it's matched to the individual. It's not one exercise that everybody gets. It's identifying the features that are relevant for the individual and then targeting that. It's matched to the functional demands of the individual patient. So we prepare them for that and train them to work in their function. And we need to think about, well, is there an impact of psychological features on that? So do we also have to address that? But in many people with nociceptive pain, those features are not so dominant. So this is the way I like to think about it in a clinical model of you first of all identify and then you train the specific features that you identify in their posture, movement, and muscle activation that are relevant for their pain provocation. So we train them how to change those features, we evaluate the impact on their pain response, and then we train them. We then progress them into situations of higher loading. So getting people to use those new strategies in function. So first of all, some static exercises where they control the alignment while they add force, and then some strategies where they're actually using movement, because again, we need this balance between movement and stiffness. And then finally, ensuring that we integrate that into function. Now, for the spine, there may be issues of breathing and continence that we also need to consider. There might be issues psychologically. There may be features at the adjacent regions. So there may be hip problems or thoracic neck problems that need to be considered as well. We need to train sensation. There might be balance features that need to be addressed. We also need to consider the muscle. They have to have sufficient strength and endurance to be able to function. And we also need to consider the person's fitness. Do they actually have the cardiovascular fitness to be physically active? So the idea of motor control is that we first of all need to assess and identify the features that are relevant for that person's presentation and address that in training. And we need to think about posture, movement, muscle activation, and sensation. So with posture, we're going to assess the way the person is holding their alignment and identify features that we think might be relevant for the provocation of their symptoms. In terms of movement, we're going to evaluate the way the person moves and identify, are there features of their movement response which are relevant for the provocation of their symptoms. With muscle activation, we're going to evaluate the whole person's muscle system. We're going to look at all different layers of muscle and identify, are there muscles that people are using too little? Are there muscles that people are using too much? And then we're going to try and intervene to change that. So, for example, we might use ultrasound imaging if it's available, or palpation to be able to evaluate the function of the deeper abdominal muscle transversus abdominis to identify, is it underactive? We'll also use these tasks to evaluate, is there overactivity of the internal oblique or the external oblique or the rectus abdominis? We'll use ultrasound and palpation to evaluate the activation of the multifidus muscle. We might also use those techniques, ultrasound, to look at the structure of the muscle. But palpation, we can identify its activity. We can work out, is a person underusing the activation of that muscle? We'll also assess their static and dynamic control. Can they control their spine when they need to in terms of stiffness? Can they move it when they need to? In terms of treatment then, what we're going to do is to find a solution to change those strategies. And it's obviously going to be individualized. So we're going to find some techniques that might involve using augmented feedback. It might involve specific instructions. It might involve an exercise that is tailored very specifically to modify someone's movement pattern or to change their postural alignment. And then we'll use a whole range of different exercise approaches to address the static and dynamic features of control and interfunction. So what I think is critical is, as I keep highlighting, we really do need to make sure that we're applying this technique to the people who are likely to benefit the most. And what I'd like to suggest is that we, first of all, through our clinical examination, would like to understand something about the mechanism that we think is relevant. And if the person has a nociceptive pain presentation, we're going to spend a lot of our assessment time focused on evaluating the way they use and load their body, and a little bit of time thinking about their pain cognitions, but primarily the movement features. And our program will involve an individually tailored program that aims to change the loading of tissues that's in a way that's relevant for the person. If they've got nociplastic type pain, we'll spend a lot more time assessing their psychology, understanding how that might be relevant for their pain presentation, and then have an intervention program that's really tailored to that. And with neuropathic pain, we're going to very much focus on considering the neural assessment, so neurodynamics, looking at trying to see if we can change posture and movement to address that, but also considering the psychological features. So I think we can try and tailor intervention based on pain mechanism, and we can also consider the amount of time that we devote to each of these interventions. So what I'd like to suggest in terms of evidence is that there is really actually very good evidence that we can change the activation of muscles, we can reduce the activation of superficial muscles, we can improve proprioception, we can improve spine control, we can improve movement. So we can change the things that we want to change. There are some clinical trials that show very large clinical effects that where it's individualized treatment applied to specific patients. And there are interventions where everybody gets the same treatment. And basically the interventions appear to be more effective if we target the intervention specifically to the individual. And we've done some recent clinical trials that show that if we choose the right patients, we can have a larger clinical effect size. So what I'd like to suggest is that treatment needs to address all of the biological, psychological, social features, but we need to think about the interaction between them, but we need to think about, well, what are the primary drivers of the person's pain? So spine control does require a balance between movement stiffness. The coordination of a complex muscle system needs to be considered. It involves a range of neural mechanisms. And we also need to remember that there is a whole range of different functional goals, and it's about this balance of movement and stiffness. Pain and motor control interact in different ways, and if we identify the pain mechanism, we can have a positive effect. Motor control can have positive and negative implications for the way that we consider the management. And if a person does have ongoing nociceptive pain, then motor control intervention is probably the approach that we would like to consider. But again, it needs to be targeted to the individual. And this is just a plug for a website that we developed for patients with pain. But I'd like to finish by acknowledging the contribution of all of the people I've worked with on these experiments. And I'm very happy to answer questions during the question session a little later on today.
Okay, thank you so much. After having such a wonderful and informative session, we will move to the next keynote that will be given by Dr. Charlotte Hager. I will introduce my second keynote speaker, Professor Dr. Charlotte Hager. Professor Dr. Charlotte Hager currently works at Department of Community Medicine and Rehabilitation, Amaya University, and is head of the U-Motion Lab, featuring 3D motion capture, force recordings, and electromyography. Her prime area of research is in physiotherapy, sports biomechanics, and rehabilitation, specifically in the field of motor control, sensory motor control mechanisms, and overall strategies for the functions of upper and lower limbs. The topic for this second keynote speaker of this plenary session is assessment of sensory motor control and consequences after anterior cruciate ligament injury. And to present that, please welcome Professor Dr. Charlotte Hager. Thank you.
Dear colleagues, I hope you're all good wherever you are. First, I would like to thank the organizers for the invitation to present in this conference. I'm so sorry we could not meet in person as planned, and I had so much looked forward to visiting Lahore, but I hope to have the pleasure in the near future. My name is Charlotte Hager, and I'm a professor of physiotherapy at Umeå University in Sweden. And I also work as a physiotherapist in the orthopedic clinic in our major hospital of the region. You can see here on the map where Umeå is located in the north of Sweden, a bit south of the Arctic Circle. I grew up way above the Arctic Circle in the true land of the midnight sun, where the sun never sets during the short summer months, which are now approaching, and the nights get brighter and brighter. That provides lots of energy. I'm going to talk about sensory motor control and how we may assess this in research in persons who have suffered an injury of the anterior cruciate ligament and what the consequences may be. An ACL rupture may happen to persons of all ages, but it's most common in young sports active individuals, especially in males. Despite this, females have more than 3 times as high relative risk to suffer an injury, although we still lack complete explanations for this. In any case, the risk of secondary injury is very high, up to about 40%, as some studies have shown, in particularly compared to those who are not sports active. Here's an example of what an injury may look like. Please observe the tennis player in the background of this video. Her knee suddenly gives away as the ligament is ruptured during a rapid twisting movement under a loading condition. And that ends badly. So while it's common knowledge that most injuries occur in sports, people may not know that the majority of the injuries are so-called non-contact injuries, where there is no contact with any other person or object. Thus, the injury may be related to poor movement control, at least momentarily. The typical movement pattern when the ligament is torn is with a relatively straight leg, the femur adducted and rotated, and the tibia abducted and rotated, and often there is a lateral flexion of the trunk. There may be significant consequences of an injury in the short and in the long term, as then demonstrated by plenty of studies. In addition to the short-term consequences of pain and giving way sensation, Later consequences involve loss of muscle strength, altered movement patterns, reduced balance, and a general perceived feeling of knee instability. These factors may prevent return to sports and lead to decreased physical activity and poorer knee-related quality of life. Fear of re-injury has also been identified as a major factor for not resuming sports or other physical activities. And such fear also implies a high risk for re-injury. Another well-known consequence is the development of osteoarthritis, where there is a large variation in individual rate of development, in which the process is very accelerated for some individuals and much slower for others. But after 20 years, over 90% or more of the injured persons have developed osteoarthritis and will in many cases need surgery with knee joint replacement. There is also a high risk for ACL injured individuals of sustaining a subsequent contralateral injury to the other knee. We have just published a systematic review with meta-analysis on such risk factors for injury of the contralateral knee. And our analysis includes data on in total up to 59,000 individuals. In fact, this risk may be even higher than suffering an injury to the ipsilateral knee, as demonstrated by other researchers. In our review, we identified 7 risk factors associated with contralateral ACL injury. And these were in the following order of magnitude as estimated by the odds ratio. Returning to high activity level as the primary one, followed by body mass index lower than 25, age under or equal to 18 years, a family history of ACL injury, primary ACL reconstruction performed 3 months or less post-injury, female sex, and concomitant meniscal injury. In relation to higher risk for both injury and re-injury with regards to family members having suffered ACL injuries, I just want to mention that we have in an international collaboration collected DNA from several countries, and our common pool of data from different populations worldwide demonstrate that there are associations to specific gene variants identified at the group level, and these seem to play a role for suffering a primary ACL injury. So altogether, there are good reasons to consider family history in risk reduction work and rehabilitation of ACL injury, especially considering return to sports decisions. Okay, with regard to assessment of function following ACL injury, what do we do? Well, in the clinics, there are common meniscal and ligament tests. And we use several different scores for knee functions, including scales to evaluate fear of re-injury, as mentioned, or so-called fear of movement, referred to as kinesiophobia, that we may assess using questionnaires such as the Tampa scale of kinesiophobia. This was originally developed for persons with low back pain. There is also a more recently developed score to assess readiness to return to sports, the ACL Return to Sports After Injury scale. There is indeed an increasing awareness to consider also the psychological consequences of the injury and their importance for the rehabilitation outcomes, also as revealed by qualitative research studies. As for physical capacity, commonly flexion and extension knee strength is measured, and a significant number of functional hop tests are used, both on 2 legs, such as drop jumps, but mainly 1-leg hops, like 1-leg hop for distance, 1-leg vertical hop or side hops, where commonly the number of hops per 30 seconds are counted, or other various side cutting tasks, to mention a few tests. However, there's no real consensus of the best test battery to apply, and therefore researchers have used different approaches to evaluate function. And as you may be familiar with, many tests are evaluated in the clinics by way of the limb symmetry index, the so-called LSI, simply taking the ratio of the value, for instance, for hop distance for the injured leg to the value of the non-injured leg. And LSI above 90% has for long been considered a good enough function. But based on research, this value is no longer seen as sufficient. Another reason for not relying on LSI is that it's well known that also the non-injured leg may become influenced, for instance, due to inactivity. Thus, the LSI may result in falsely high values. So several recent reviews call for evaluation of the movement control in rehabilitation. and not only looking at the knee joint, but also to analyze whole body movements in order to understand injury mechanisms and risk of re-injury. This is a true challenge for researchers to figure out how to best do this and perhaps reach some common kind of grounds in the future to facilitate evidence on across studies. So importantly, when we consider the causes for and consequences of ACL injury, it's not only about biomechanics, but definitely also about sensory motor control. Most of our movements are controlled in an anticipatory fashion. That is, we select motor plans that are executed through motor programs based on internal representation, often so-called sensory motor memories that we have built over time by way of practice. We learn by experience how to carry out a certain movement, and we fine-tune it over time, often many years. For example, we know exactly how high we have to lift our foot while negotiating the stairs at our home, and how much force we need to grasp a coffee cup that we use daily. We only notice or update this upon imposed changes. Sudden pain or dysfunction may arise and influence these processes in many different stages and locations within the central or peripheral nervous systems. For individuals with distorted sensory motor control, there might also be difficulties to store or use or update these memories to control their movements accordingly when the central nervous processes are affected. This has been shown in various clinical populations, such as children with cerebral palsy, for instance. So solutions to improve rehabilitation outcomes and enable successful and safe return to sports may largely be about understanding and improving movement control and movement quality. But how do we do then to assess these persons who have suffered an ACL injury, and what can we learn from it? One way to investigate the sensory motor control is to use detailed motion analysis in laboratories. A core facility for my research group is our U-Motion laboratory, where we use high-speed cameras emitting infrared light that is being reflected back to spherical markers that we place on specific anatomical landmarks of the body. So we record movements, in this case, a side hop test. And we can then build a model based on the movements of the markers, which provide us with accurate information about the movement patterns of the individuals. That is three-dimensional kinematics in the sagittal, horizontal, and transversal plane in different tasks, here exemplified by a mean knee flexion curve as seen to the right, the green curve, with respect to a normal reference population, the lighter shaded curve area, including standard deviation. We also used force plates to record ground direction forces in order to calculate moments and power around the joints. The moment curve is exemplified in the middle panel to the right, indicating knee abduction and adduction moments. And finally, we can also record electromyographic activity of multiple muscles producing the forces that generate the movements. All these data enable us to build up a comprehensive analysis of an individual's movement control, which may be complemented by clinical tests and questionnaires on self-reported outcome measures. We have conducted a large study investigating outcomes of ACL injury in the very long term, where we had the opportunity to carry out a follow-up of 2 carefully studied cohorts who suffered an injury more than 20 years ago. The first one was from a specific hospital that had as first-hand treatment physiotherapy in combination with reconstructive surgery. And in the second cohort from a different hospital, they prescribed predominantly physiotherapy only. In addition to survey data, we focused on functional status and movement capacity in applying a rather large functional test battery, where we could then separately for each group compare the outcomes to healthy asymptomatic, aged and gender-matched control. Since it was not a randomized controlled trial, we cannot make direct between group comparisons regarding treatment effects, but it's still a valuable source of information. Movement patterns and motor control strategies were investigated in several functional movement tasks involving different hops on 1 or 2 legs, 1 leg rise, squats, balance tasks, and stair descent. We made specific hypotheses for comparisons between injured and non-injured leg for the ACL injured groups, and chosen parameters were tested in relation to those of healthy asymptomatic controls. We observed altered movement strategies in all of the hop tasks for ACL injured persons compared to controls. Different strategies used for those who had surgery compared to controls than those who did not have surgery. And not only for the knee joint, but also for the trunk and hip, for instance, which may seem logical, exemplified here with the one-leg vertical hop jump. But this was true also for the one-leg hop for distance, for example. So in relation to which functional tasks to evaluate and what to focus on in the analysis, there is a just published very interesting study by Kotsifaki and co-workers. They showed that it's especially important to look at the knee in the landing phase of hops, where the knee is the main absorber and stands for about 65% of the total work in a horizontal hop, such as the one-leg hop for distance. So individuals with an ACL injury often find the side hop particularly challenging for the knee. So following our long-term study, we therefore developed standardized side hop test, particularly suited for detailed motion analysis, rather than the traditional side hop test that is more evaluating endurance and does not provide any outcome measures on the hop, how the hop is actually controlled. We compared the knee control in our standardized side hop test to that of one-leg hop for distance and the vertical hop. Side hops indeed challenge the knee control in the frontal and transversal plane much more than hops for distance or height among ACL reconstructed individuals. We have in several different papers showed that the usefulness of applying also a finite helical axis analysis of how much such a combined axis moves through a joint during various tasks in order to assess dynamic knee stability. This has demonstrated the value of side hop in particularly as a more challenging test compared to other tasks. So we also analyzed the dynamic knee stability, that is the knee robustness, if you will, as a measure of how sensitive it would be to a destabilization during side hop landings using a finite helical axis approach. We found that persons who have had ACL reconstruction still manage to maintain a normal knee robustness, but their whole body movement strategies instead differed from controls. With reference to sports situations, we also designed a new double hop test aimed to simulate risky situations where you have to take fast decisions on change of movement directions. That is challenging for the knee and the ACL. Remember that the rupture most often occur in the non-contact situations. Our study was, as far as we know, the first to compare biomechanical asymmetries and motion strategies used during anticipated and unanticipated diagonal hops between limbs, dominant versus non-dominant, injured versus non-injured, and groups, ACL injured versus ACL intact. For this test, the participants stand on one leg on a force plate and hop forward at a predetermined distance that we chose to be 25% of body height onto another force plate. And then this is followed by a subsequent 45 diagonal hop to either the right or the left. The direction of the 45 degrees hop is guided by a light signal as at takeoff from the first hop and randomly displayed either to the left or right on the floor, the unanticipated condition. During the anticipated condition, the visual cues regarding the 45 hop direction are provided prior to each trial. Our test provides reliable results, and we have published those contrasting predictable and unpredictable jump directions in ACL injured persons and asymptomatic controls. Knee joint peak angles and most peak moments were higher in the unanticipated than in the anticipated lateral diagonal hops for both ACLR and uninjured legs. The relatively large hip and knee movements in all three planes during unanticipated lateral diagonal hops particularly challenged dynamic knee control. The test may thus provide valuable information for evaluation of function in rehabilitation. It may be used as a clinical test also by therapists simply using their voice to provide directions and observe or video record the performance. The success rate is quite informative and will be pretty obvious if the person actually managed to jump in the correct direction, or if he or she just guesses beforehand and ends up to the wrong side, or use a double knee flexion after the first jump, or does not manage to stick the jump and maintain balance in the last square. In our long-term study, we also looked at balance, as mentioned. Over the half of the ACL injured persons, now on average around 47 years old, could not stand on their injured leg for 30 seconds as a common test. This was regardless of whether surgical reconstructions was included in the treatment or not. All matched controls, on the other hand, could stand on one leg for 30 seconds. More surprisingly, this was the case also for the non-injured leg. Most ACL injured persons could not maintain balance on the non-injured leg, while all controls could do that without problems. So 2 different legs, one injured and one non-injured, but the same brain. That led to the thoughts to look into the literature, where we found also other research evidence for altered sensory motor control in general following an ACL injury, indicating altered sensory nervous processes, and not only consequences related merely to the injured knee. There were also different kinematic balance strategies for ACL injured compared to controls for standing on 2 legs. In fact, if looking for evidence of neuroplasticity and effects on the brain, Caprelli and co-workers were the first to address brain plasticity following ACL injury by using functional magnetic resonance imaging. They looked at brain activity of these ACL injured individuals when performing a simple knee extension flexion movement, and they saw decreased activity of sensory motor cortical areas and increased activation in other areas for the ACL injured group compared to controls. Since then, several more studies using similar paradigms have suggested that an ACL injury may lead to modified brain activation pattern. So we set out, in addition to just looking at movements, to try to assess the proprioceptive ability of ACL injured person. It has been under debate whether the ligament injury with presumed loss of receptors leads to reduced proprioception, which in turn might explain some of the sensory motor control deficits and the altered movement strategies. We conducted a series of systematic reviews to establish the evidence for how to best assess proprioception, and also answer the question whether there really is reduced proprioception following ACL injury. And what is the evidence for that, as we as physiotherapists can help persons to train and improve their proprioceptive ability, which we often claim. Currently, there are 2 major test methods to assess knee proprioception. One addresses knee joint position sense, in which the individuals are to move to a certain knee joint angle, memorize it, flex or extend the leg, and then retrieve a particular knee joint angle, usually with the same leg. The other method is to detect a threshold for a passive joint motion. In our first paper, we looked at methods to assess joint position sense, and we analyzed 80 papers with data on 119 knee JPS tests from in total 2,475 participants with a unilateral ACL injury. The results of meta-analysis shows that there are sufficient validity for the method, and it demonstrates that there are larger target angle errors for ACL injured knees compared to non-injured knees. There is, however, insufficient quality for responsiveness and reliability, which is of course worrying, and there is a need for consensus around the best way of testing and how reliable the tests are in order to fully compare results of different intervention studies to evaluate the best treatment and rehabilitation for ACL injury. This work led us to develop 2 novel JPS tests, one in standing with weight bearing, which seems more sensitive, but also one similar test in lying, and we have proved them to be reliable. But we also found that physical activity level of the participants matter. Those with higher level produced less errors. Our lying test was developed with a particular goal of being able to introduce the test in an MRI scanner to better address the impact of ACL injury on knee proprioceptive acuity and how this is reflected by functional brain response. We installed non-magnetic fMRI compatible motion cameras, the latter being a totally novel line of research that nobody has done so far. This opens up opportunities to examine, for instance, the natural history of brain processing during rehabilitation following ACL injury, but also to investigate if so-called proprioceptive training is sufficient in resulting in smaller joint angle reproduction errors accompanied by changes in the brain activity. And can it help prevent re-injury and facilitate safe return to sports? These are answers, the research questions that nobody knows at present. Or at least it's not reflected in current research, as we show in a just published other systematic review, where we scrutinized almost 3,000 studies to find evidence for proprioceptive, or as we ended up calling it, neuromuscular training, as it is often referred to. So we asked if training can improve proprioception. Out of all these papers, only 9 met the required inclusion criteria to answer this question, which meant a total of 327 persons with an ACL reconstruction. Neuromuscular training interventions varied: whole body vibration therapy, Nintendo Y-Fit training, balance training, sports-specific exercise, backward walking, etc. But the certainty of evidence was unfortunately very low. So there is still no evidence for this, and the question remains unanswered until we have better methods and thus improved intervention studies. We have also developed some more functional tasks, presumably reflective or reduced sensory motor control following injury. In a step down, that is stair descent task, we analyzed mean 3-dimensional face plane graphs for hip, knee, and ankle flexion extension by implementing a so-called generalized Procrustes analysis between joint angular displacement. We computed a dissimilarity index based on this that would be close to 0 if the coordination was totally symmetric for the legs in these tasks. In A here in the panel, you see data from a person with an ACL reconstruction, and in B, data from a healthy knee control, where the lines are very overlapping for the coordination between all the joints of one leg. The value of the comparison between the non-affected leg and the affected leg for the person with ACLR is nearly 9 times larger than that of the comparison between the dominant and the non-dominant leg for the control person. This clearly shows an asymmetric interjoint interaction after ACL reconstruction, and our preliminary data show that this asymmetry may still be present as long as 2 years following rehabilitation for some individuals at least. The traditional outcome measures do not capture this discoordination. Another test that we developed is a more functional test challenging the sensory motor control following injury, intended towards more of a clinical testing eventually. This is an obstacle clearance task in which 37 individuals who had ACL reconstruction and 41 asymptomatic controls stepped over a hurdle-shaped obstacle. Downward vision was occluded, aiming for as little clearance as possible when they first put their foot on the obstacle, removed it, and then stepped over, but the obstacle was removed without their knowledge. The coordination analysis revealed sensory motor deficits in persons post-ACL reconstruction. Greater asymmetry and less variable, that is more stereotypical trajectories, were found compared to controls. And as I already mentioned, fear of re-injury, which is also often associated to kinesiophobia, that is fear of movement, seems to play a major role for the outcome of rehabilitation of ACL injury. Although these different concepts or their relationships and how to assess them are currently not entirely clear. And indeed, in our long-term follow-up after more than 20 years, all the functional outcomes such as hop distance, hop height, and number of side hops correlated with a score on Tampa scale of kinesiophobia. The greater the fear of movement, the lower the jump capacity, which may not be that surprising. So in a recent study currently in report resubmission phase, we divided participants who had had ACL reconstructions into 2 groups, according to one question from the Tampa scale of kinesiophobia, namely whether they were afraid of injuring themselves accidentally. About half of them stated, I strongly agree or I agree, resulting in a high fear group. And the other half reported no or low fear. We then compare the muscular activation of these two groups during the standardized side hop and also to that of an aged and sex-matched asymptomatic control group. Our results show that the high fear group displays higher mean amplitudes of biceps femoris muscle activity and quadriceps hamstring co-contraction during landing. Groups means with 95% confidence intervals are shown. This suggests that altered neuromuscular control may be a consequence of fear of the injury. I can mention also that the total score of the TSK kinesiophobia was clearly different, where high fear showed a higher median score than the low fear group. For those of you who are interested in sports physiology and injury management in general, I can recommend a recent book edited by James Richards, in which we also have a chapter on ACL injury management. So there's more time than now to go into different details. And by this, I would like to thank all the funding agencies, collaborators, and all participants for their support. And of course, my research group with different disciplines involved, and our main international and national collaborators. And also to all of you, thank you for listening. And I wish you a great conference, and I send greetings with this image of the spectacular northern light that is typical of the skies in our parts of the world. Thank you.
Okay, thank you so much, ma'am, for sending us such an informative and innovative presentation for our conference. Now we will move to the third keynote speech of today. Our presenter, Dr. Habiba Thawer, has already joined us for the live session. I would start with the introduction of Dr. Habiba Thawer. She is a certified functional evaluator. She is certified by the American Board of Forensic Professionals in the rating of impairment and disability based on the AMA guides to the evaluation of permanent impairment. She has completed training in the areas of manual therapy, chronic pain, and acupuncture. She did Bachelor's of Science degree in physiotherapy from the University of Western Ontario in 1997 and graduated with the master's degree in 1999. And she holds a PhD in rehabilitation sciences in 2002 from the University of Western Ontario. She is registered with the College of Physiotherapists of Ontario and an eminent member with the Canadian Physical Therapy Association. The topic for the third keynote speaker of this plenary session is efficacy and effectiveness of tele-rehab and its impact on patient care in the context of current pandemic. And to present that, I welcome dear Dr. Habiba Thawer. Please, ma'am, over to you. May you please hear us?
Hi, thank you so much. I'm going to share my screen. Please verify that you do see it.
Okay, thank you.
Okay, thank you so much for inviting me to speak today. It's an honor to be here. This talk is going to be a little bit less technical than the previous ones we've had today. I've decided to share with you one of my experiences as I was volunteering at the Aga Khan University in 2019 and 2020, when the COVID-19 pandemic was identified and began to affect all of our lives, including our patients' lives. So I hope that you find this, what I like to call story versus presentation, inspirational, encouraging, motivational, and I hope that you garner some some positive energy and momentum from this story. So let's begin. So when the lockdown happened in Pakistan, I believe that was in March or April of 2020, at the Aga Khan University Hospital, although we remained open, although our physiotherapy, speech therapy, and occupational therapy services remained open, the majority of patients were not able to attend because of the lockdown. And as a result, we weren't able to provide continuity of care to our patients. And this was not unique to just us. The WHO noted that rehabilitation services had been disrupted in almost 2/3 of countries secondary to the COVID-19 pandemic. And I found this alarming, as the WHO has stated, that the total number of years lived with a disability globally is linked to health conditions for which rehab is beneficial. Acknowledging that Pakistan is considered a lower middle income country, or rather economy, and that of the estimated 1 billion persons with disabilities worldwide, 80% come from lower to middle income countries, the COVID-19 pandemic further impacted access and provision of rehab in Pakistan, pardon me, compounding the growing imbalance between the population and available resources due to the country's rural landscape, virtually non-existent health governance, and funding, and a large portion of the population that comprises a lower socioeconomic bracket. So I just touched on that, how the lack of accessible rehab during the pandemic and the lockdown affected Pakistan's patient population. So at the Aga Khan University Hospital, our goal was to think about ways in which we could try to maintain some continuity of care for our patients. And what we thought was, let's examine or let's explore whether telerehabilitation can in some part try to fill the gap of continuity of care. So before we begin, what exactly is telephysiotherapy? Telephysiotherapy is quite simply the delivery of physiotherapy services via telephone. It could be a landline or a mobile, video conferencing such as Zoom, as we are doing today, and the internet using various platforms, whether it's FaceTime or Microsoft Teams, etc. So it's using technology to deliver physiotherapy. Telerehabilitation encompasses multiple forms of therapy: physiotherapy, speech therapy, personal training, as well as occupational therapy. You may have also heard the terms of telemedicine, telehealth, and again, those encompass delivery of healthcare services through the use of technology. Now, what we discovered when we were at the Aga Khan University Hospital, when we were looking at whether or not using telerehab and telephysiotherapy would be a viable option for us as clinicians, as an organization, a tertiary care hospital, as well as for patients, we understood that there were several barriers that existed that could make implementation of this phenomenal innovation somewhat challenging. And these included skepticism amongst the stakeholders about the effectiveness of telerehabilitation and telephysiotherapy. Stakeholders included patients. Some patients had misconceptions about what exactly telerehabilitation entailed. And there was also a lack of literacy and technical knowledge amongst the providers, the physiotherapists, the OTs, the speech therapists, and also the end users, the patients. Some of them weren't aware of various platforms such as FaceTime or Zoom. And anytime there's an introduction of a new technology or a new SOP, a new program, there's some resistance that we encounter among stakeholders. So there was some resistance to adopt a new way of doing things. And there were mixed attitudes and varying levels of satisfaction toward the use of telerehab amongst our staff. And of course, the presence of undependable broadband internet and speed throughout the country. And this can occur not only in the rural areas of Pakistan, but also sometimes in the urban areas. We were fortunate at the Aga Khan University Hospital that we have a robust IT infrastructure. So at least on our end, the broadband availability was robust. And we were also fortunate to have a dedicated team of IT professionals who partnered with us and provided us with assistance in implementing these sessions. This program's implementation could not have been possible without our IT professionals' ongoing assistance and help. However, when we looked at the benefits that telerehab could offer, we concluded that the benefits greatly outweighed the barriers, and particularly relevant to Pakistan. Providing rehabilitation using technology negates the need for transportation, negates the need for patients to arrange for transportation to travel to our OPD. And it allows patients to engage in physiotherapy, speech therapy, occupational therapy in their homes, thereby facilitating continuity of care and providing the expertise of our therapists to patients virtually anywhere using telephone, video conferencing, the internet. In a busy urban area such as the city of Karachi, the city of Lahore, the city of Islamabad, telephysiotherapy offers the option of providing a hybrid model by combining in-person and virtual sessions to augment existing programs and to implement new programs. It also offers, in my mind, a cost savings because, again, patients don't have to arrange or think about childcare as they come to the OPD. They don't have to think about paying for arranging transportation. So it does offer some cost savings. And it also provides a level of social interaction to patients. We were able to do this primarily through physiotherapy by offering small group sessions. So providing physiotherapy, largely exercise-based physiotherapy to groups of 2 or 3 patients at one time. And in a time where social interaction was greatly curbed, these small virtual group sessions permitted a amount of social interaction for our patients, which they found quite satisfying and rewarding. And most importantly, during a pandemic, telephysiotherapy and telerehabilitation offers access to patients for assessment, treatment, monitoring, and progression while mitigating the risk of infection, cross-infection, et cetera. So clearly, we found that the benefits outweighed the barriers, and the benefits that you see here, many of these we actually experienced and our patients experienced firsthand once we implemented our telerehab service. Now, how did we go about implementing our program? Because You heard earlier how I described the barriers. We had to consider many things, such as how do we obtain consent for our patients. Normally, this is done in writing. So how do we go about obtaining consent? How do we book appointments? How do we provide educational material, exercises, for example, to our patients? So these were all things that we had to think about. So the first thing we did was we ensured that we had an infrastructure to allow us to actually deliver these tele-rehab sessions to our patients. And as I mentioned earlier, at the Aga Khan University Hospital, we have a robust, we have access to robust broadband and a fantastic IT department. And so we realized that we did have the infrastructure to support implementation of the program, including an adequate number of laptops and an adequate number of private spaces in which therapists could use the laptops to deliver the tele-rehab sessions to patients. However, not a single therapist in our department had ever engaged in tele-rehab. I had engaged in it prior to coming to Pakistan, and I was actually engaging in it while I was in Pakistan, providing consulting services to patients in Canada, and I was using telephysiotherapy to do that. So we then looked at conquering training, and I'll get into a bit of detail about that, and mentoring, and then of course advertising to our patients that we have this service available to them. So in regards to training and mentoring, I was fortunate that I have colleagues in the United States and in Canada who are part of the Ismaili Health Professionals Association and who are part of the Aga Khan Health Services. And in conjunction with my colleagues, we were able to design a training program for providing safe and compliant tele-rehab services. And this webinar consisted of occupational therapists, speech language pathologists, and physiotherapists. And these are all individuals from the US and from Canada who are experts in their areas of practice. And we were able to bring them together and provide a 3 to 4 hour training session to our inpatient and outpatient staff, not only at AKUH, but also at the Aga Khan Hospital in Mombasa, in Kisumu, in Dar es Salaam. So this was the pillar of our training. And then there was individual mentoring provided to our therapists as needed. And what I found as an observer was that there were 2 or 3 key therapists who really embraced telerehabilitation. And when other therapists saw the results that they were obtaining, then the other therapists also began to become excited and chose to engage in the practice. And this is how we at the Aga Khan University Hospital in Karachi were able to grow our tele-rehab services and provide continuity of care to our patients. So this is just a quick breakdown of statistics that I gathered. The lockdown in Karachi began in March, and by April, we were implementing tele-rehab sessions. So within 3 weeks, we were able to verify our infrastructure demands and needs, provide training and mentoring, and then actually reach out to patients and provide the service. So the blue bars represent physiotherapy sessions. The orange bars represent occupational therapy sessions. and the gray bars represent speech therapy sessions. Now, I must warn you that not every single patient and not every single condition across rehabilitation is suited for telerehabilitation. There are some conditions that respond really well to this type of environment, and there are some conditions that don't. So generally, it's been my experience, as well as looking at the literature, any sort of activity or exercise-based intervention can be completed quite easily using telerehabilitation. As well, any type of coaching, guiding type activity can be completed very well using telerehabilitation. And if you were to do a literature review today, you would see that there are a plethora of studies that show that telerehabilitation is as effective as face-to-face rehabilitation for many, many conditions. Many musculoskeletal conditions like patellofemoral pain, chronic and non-chronic low back pain. And of particular interest to me was how effective telerehabilitation was in cardiac rehabilitation. It was found to be just as effective for cardiac rehabilitation as in-person sessions. These are just a few examples of the conditions and types of injuries where telerehabilitation can be utilized. So as you can see, we did quite well. As the lockdown resolved and patients felt safer to return to the hospital and to our OPD, our sessions decreased, but we were able to maintain them. And I really think that going forward, there'll be an increasing use of telerehabilitation, particularly in a hybrid model where perhaps a patient initially comes in for an initial assessment, and then the subsequent 3 or 4 sessions may be done using telerehab, and then the patient returns for the 5th session for a reassessment in person, something of that nature. I think that is a model that many patients find favorable. I'm currently in Canada, and this is typically what I do with my patients is I usually see them in person initially, and then we have 2 or 3 sessions using telephysiotherapy. And then the 4th or 5th session, they return for an in-person session for a reassessment, and then we continue for additional sessions using telephysiotherapy. So the option for a hybrid model, I think, is appealing for both clinicians as well as patients. And in a low and middle income country such as Pakistan, where cost is a significant factor for patients, allowing them to engage in a hybrid delivery service model, I think, offers tremendous advantages, one being savings in financial cost. So these are a few pictures of our team. This is a therapist. This is a therapist providing cardiac rehab using rehab to patients. This is one of the group sessions I talked about. We kept the group sessions to a very small number, no more than 2 or 3 patients per group session. And these were actually patients with Parkinson's disease, and our therapist is guiding them through an exercise program here. And I think one of the most popular applications was in pediatric rehabilitation. So we had our pediatric occupational therapists, our pediatric physiotherapists, and our pediatric speech therapists connect with their pediatric patients with the assistance of a parent and or an attendant to implement the service. This is a testimonial from a patient that I and a colleague saw together. This individual was in his late 70s. He had a diagnosis of Parkinson's disease. And I will read his testimony to you. Oh, before I do that, before the pandemic, he attended our OPD regularly for group exercise sessions with a group of patients with Parkinson's disease. So when the lockdown happened, he was unable to attend those sessions. He lost the majority of his social contact, which came from attending those group sessions. He reached out to me personally, and we were able to arrange tele-rehab sessions for him. And this is what he said. This meaning the lockdown seriously affected my Parkinson's disease and my mood. My stiffness and slowness both increased, and there was a perceptible decline in my gait and overall health. I also lost about 7 kilos from my former weight of 76 kilos, got very positive response from the Aga Khan University Hospital. I was able to start having regular Zoom sessions. This greatly improved my mood and overall health, and enabled me to face the downsides of isolation and lack of movement. So this is the reason why we implemented telerehabilitation, was to reach our patients, such as this one here, and to provide continuity of care. This is the second testimonial I would like to share with you. This was a patient who was very active before the lockdown. She had multiple comorbid conditions, diabetes, high blood pressure. She was overweight and was very concerned about her weight. She would attend for swimming at the Aga Khan, at the Sports and Rehab Center at the Aga Khan University Hospital, and she would walk regularly outside of her home. However, when the lockdown occurred, because of her comorbid conditions, her family became very protective of her, and she couldn't attend for swimming, and she couldn't walk outside of her home for risk of contracting COVID. So her daughter reached out to me, and I was able to arrange with my colleagues at Aga Khan University Hospital Physiotherapy Department rehab sessions for her using tele-rehab. And her primary goal was weight management and weight loss. So I did a preliminary assessment with her online, and then I was able to put together an exercise program with her, which we implemented over several sessions. And I'd like to read to you her testimonial. COVID-19 has made it more vulnerable, as due to my age and underlying conditions. My family did not allow me to go out and walk anymore. She, referring to me, customized a home fitness program for me and gave me a structured teleclinic support to pursue it. I started seeing significant change in my body. It felt so light, my increase in stamina and energy levels. After the third and fourth week, I started seeing that my waistline reduced to 2 inches and my weight dropped to 2 kilograms. It is my third month in the program, and I feel so energetic, motivated to make healthy choices for my life, have enhanced self-esteem, and most of all, I now think I can also take care of my health. I can't thank physiotherapy department at the Aga Khan University Hospital enough for this life-transforming journey and enabling me in times of COVID-19 to make healthy lifestyle decisions with my limited resources, with my growing age and underlying condition. This program is so impactful in so many ways. So, when I see testimonials like this, it's quite, it makes me quite happy. This is the reason why I became a physiotherapist. And this technology has allowed us to reach so many patients throughout Pakistan, as far as Multan. So in closing then, I'd like to just sort of drive home the point that, tele-rehab is an opportunity for us to provide accessibility of rehabilitation services to our patients throughout Pakistan. It allows us to empower our patients and to arm them with hope. And just to remind you what the WHO has said, the enjoyment of the highest attainable standard of health is one of the fundamental rights of every human being without distinction of race, religion, political belief, economic or social condition. As rehabilitation professionals, we have the knowledge and the ability to positively impact on our patients' quality of life. And I think that just as acupuncture, manual therapy, exercise therapy are tools, telerehab is now an emerging tool, particularly in the age of COVID-19. At the time that I devised this presentation, the weekly epidemiological update on COVID-19 for April 20th, 2021 from the WHO noted that globally, the number of new COVID cases rose for the 8th consecutive week, with over 5.2 million new cases reported in the last week. The number of new deaths increased for the 5th consecutive week, increasing by 8% compared to the previous week, with over 83,000 new deaths reported. And although this is a sad, unfortunate, and even scary state globally, I think this is also a time for innovation in our profession by integrating telephysiotherapy and telerehabilitation into the routine delivery of rehab to patients, thereby transforming the role that physiotherapy and rehab can play in contributing to the functional independence and quality of life of patients with disabilities during these challenging times. Thank you so much. If any of you wish to contact me, you can do so through my AKU email. I can provide you with references on studies showing the effectiveness of telerehabilitation, or if you have any other questions in regard to this presentation, please do contact me to discuss further. Thank you so much for your time and consideration.
Thank you so much, ma'am, for your inspirational and motivational speak about the telerehabilitation. This is one of my area of interest, but I had never get a chance to do this telerehabilitation. But after having your lecture about it, I myself got an inspiration that we should do that. Thank you so much for this. The professionals like you are the asset for us. Thank you, ma'am. Our next keynote speaker is Dr. Yvonne Frizzell. She's also here for the question answer session, but her presentation we do have in the form of recording. So we will start our fourth keynote speaker speech with her. We will start with her introduction. She is a chartered physiotherapist qualified from the Royal London Hospital, UK in 1977, and she is now director and service developer of Akbar Kare Institute, a busy pediatric rehabilitation center that offers all services free to the families having children with disability. For the last 15 years, she has been working in Peshawar and is a founding member of AKI, Akbar Kare Institute. She developed a professional educational website that record over 14,000 participants in 179 countries, when it ran a 6-week MOOC managing children with cerebral palsy. Her experience of managing a young boy with cerebral palsy with complex needs provides a depth of appreciation for the need to provide comprehensive services in partnership with the families of children with disability. The topic for the fourth keynote speaker of this plenary session is early recognition of atypical neurological development. What skills do we need to promote early referral for early interventions? For this, we welcome Dr. Yvonne Frizzell for the keynote speech. Thank you so much.
Good morning, everybody. I'm Yvonne Frizzell, I'm a physiotherapist, and today I thank you for letting me speak about the early recognition of atypical neurological development for early referral by you for early intervention. I have been working in Pakistan for the last 16 years, and before that I was here in the 80s, again doing voluntary physiotherapy work. But in the last 16 years, I have been working to develop a service, a family-centered service for rehabilitation for children, mostly with neurological problems like cerebral palsy. About 60% of our children have cerebral palsy, but we also see spina bifida Down syndrome and the multitude of genetic issues and the dystrophies. In fact, we have any child who comes to the door with their family will be seen by us for assessment. So the reason I have been involved in this is because when I was here earlier in the 80s, I made friends with a family who had a son who had cerebral palsy. And I would see him most days during the week. He'd come to my house and we'd do things. He was only 3 at the time when I first met him. So when I left Pakistan for the first time in 1989, with my husband and 2 children, we went to Ireland, and this little lad became a little bit bored with life. So he has cerebral palsy, complex needs, and quite an involved case. So after some time, it became obvious he needed more support. So he came to us in Ireland because his family were very good friends of ours. And he grew up with us from the age of 8 until 21 in Ireland in my family. So when my children went to university and I left Ireland, he went back to his family with us as well, backwards and forwards, Pakistan, and we saw him all the time. And his mother said to me, let's start something for children in Pakistan. So we did. And Aki now, Akbar Care Institute, we call it Aki. Aki now has seen nearly 17,000 children, and we are quite a comprehensive service. So I have been working for about 40 years in paediatrics, but the last 16, so a good proportion of those in Pakistan. So let's see, do I think, or do you think, early intervention should be a priority in Pakistan? Can we do better for children with disabilities and their families? And then what skills do we need to develop to get us to see these children early? How do we know they need to be seen? In 2019, Aki, as a group, we decided to do a survey on why there were barriers to early intervention. Before we did this, put this survey together, we had 10 focus groups, so that we had the service providers and the service users. And we were rather shocked to find that 1 in 4 of the professional service users had no knowledge of early intervention. And they also believed that babies needed to be left to get strong before you should start. And the parents had no knowledge of early intervention, but 80% had no knowledge because nobody had ever spoken to them about this. This is something that doesn't happen as a routine or regularly in Pakistan. In our province, Khyber Pakhtunkhwa, girls get married quite young. This is culturally acceptable, and we don't make any comment on this. But we are concerned when some of them are very young, and actually 42% are married before 18. Of course, when a girl gets married young, she tends to give birth quite early. So again, 31% gave birth before 18, and some of them extremely young. So what does this mean? These children, these mothers who are basically uneducated, 75% almost of mothers had no education, and over 50% of fathers. And UNICEF did a survey in 2017 or 18 on nutritional status of women and children in Pakistan. And these mothers who are very young, giving birth very young, often themselves have vitamin D deficiency, anemia, micronutrients deficiency, and maybe underweight. They're not really prepared to give birth to a child. And when a child with disability comes into the family, that's even harder for them. So Aki sees about 13% of children under 2, and even smaller percentage are under 1. So here's some of the parents' experience, particularly the fathers, were very hard to read these focus group discussions. So, they're looking for, how can I get help for my child? Every parent loves their child, and they're dying to do the best, literally dying sometimes to do the best for their child. And we're not, as professionals, serving that need, their child's need. In the first few years of life, there is rapid development. Why do we want to see them early? Because the brain is changing so much in those first, from birth until 2 to 3 years of age. And if we can see them then we can stop perhaps some of the maladaptive behaviours of children who cannot learn on their own. So is it nurture or nature, or nature or nurture? Nature is our genes, but the experiences we have change what happens, because these neural signals launch production of gene regulating proteins inside the cells, and these absolutely work on the genetic markers to either switch them on or switch them off. So it's both nurture, and so the experiences and our genes make us the unique people we are. And nurture is in early intervention. So how do we know which children to send for early intervention? How are you going to know, do I send this child who's just a little delayed in sitting up, or what is the problem? In 2017, Professors Novak and Professor Morgan gave us international guidelines for recognition of developmental delays, and there is strong evidence that early recognition is possible. And what they told us was that Prechtor's General Movement Assessment, GMA, is highly sensitive and specific for identifying cerebral palsy and other developmental delays by 20 weeks post-term age. We'll come to that, what GMA is, in a moment. The Hammersmith Infant Neurological Examinations, both the HNNE and the HINE, so the HNNE is for neonatals and the HINE is for infants, from 3 months to 36 months will give us a lot of information as well. So if you don't have the GMA qualification, this one you can have, and I'll go into that again in a few minutes. And then the third thing they said was MRI or cranial ultrasound. Now, I have a story to tell about MRI, which is not really very positive. We have so many children coming into the clinic, and they have an MRI creased and in a mess and dirty, wrapped up, rolled up, put in a plastic bag. They come to us, they show this expensive thing they've had done, and then we read the report, brain atrophy. Brain atrophy tells us absolutely nothing except that that child has not had experiences. They haven't yet had that nurture to be able to develop and learn. So the next slide I'm going to show you will include a video, and it's of Professor Christa Einspieler, who is my tutor in GMA. I'm an advanced practitioner of GMA, and she developed this as a student with Professor or Dr. Prechtel, who unfortunately is now deceased, and she is still doing a lot of research and training all over the world. So we'll play that now and you can listen.
Tool to early assess the function of the developing nervous system at preterm age, at term age, at the first weeks post-term, first months post-term, so until 5 months, and it's based on the differentiation of normal and abnormal movements. There are only 5 abnormal movement patterns, which are age-specific, and there are about 2 normal movement patterns specific for the preterm and term age and for the 3 to 5 months. I think the assessment of these general movements is the most cost-effective neurological examination, because you just need your eyes. Of course, a knowledge, how are normal patterns, how do they look like? And if you are more sophisticated than just watching, you have also a video camera, which is nowadays in every cellular phone. By recording the movement, you can share it with another professional, you can store it, you can always go back and check again. But usually it's about pattern recognition. So the professional assessing these movements recognize the normal pattern or the abnormal pattern and differentiates this both. If you do that, it takes a few minutes. If you are experienced, it just takes 1 minute. So it's very quickly done. It's very cost effective. And it has, if you can imagine, it has the same predictive power than a magnetic resonance image, which is very complicated, a burden for the babies, very expensive. However, I don't say that the general movement assessment can or should substitute the MRI, the magnetic resonance image. Usually it's important to have both informations, because the one is the structural information about the brain structure, the MRI, and the other is the information about function of the nervous system. The baby is by no way disturbed by just being observed, and even more so you can apply it in a neonatal intensive care unit, so the baby could be on the CPAP, can be really intensively cared for, and nevertheless you can assess the movements. There's only one limitation: if you have a sedated baby, then you cannot assess movements, but that is obvious. Yeah? Usually the main professions participating at such training courses are neonatologists, pediatricians, neuropediatricians, rehabilitation doctors, and therapists.
Email me and I'll tell you all about it. So the next recommendation that came out of the 2017 recommendations for early intervention, for early recognition, was the Hammersmith neurological examinations. And I've said before, one is for neonatals, so we have the HNNE, and one is for infants, which is HINE. And this assesses tone, motor patterns, observation of spontaneous movements, reflexes, visual and auditory attention, and behavior. And then the infant neurological examination has 26 items. And these are really quite easy and quick to administer, these two different types of tests for the two different ages. So I'm just going to show you now one item, and this is a baby being assessed for lateral tilt reflexes and adaptation to movement. And then in a moment you'll see a 21-year-old, so the neonatal and the infant. And he's observing where she's holding her head, where she's holding her arms, and you can see here that this little boy doesn't manage to get his legs right up, and he's older, so he should be able to. He's not righting himself in space. And so now, what do you do with these observations? We just move this on to the next slide. Okay, and now this is a lovely score sheet. So this is what you do, and here is what we find. So it could be any of these. Here is what we find, and you just circle it. And then after you've done that, you will find where did you circle, and this is your score. And if you see an asymmetry, then you'll score it in the middle. So this is very easy. And and then after that, you add up all your scores, you collate them, and you'll get to a global figure, which will tell you what percentile is, or what their normal range is. And then from that, you have your scores, and you can say we are likely to have a unilateral cerebral palsy, quadrilateral, they may walk, or they may be in a wheelchair. So it gives some predictive value, and everybody knows that the first thing parents want to know is, will my child walk? And so you can give realistic advice instead of something that is uninformed. So Hine scores at 3 to 6 months will give you these idea. Now, of course, I'm not advocating you actually say, oh, they will have a GMFS of 1 or 2, but you have the tool yourself to know how to counsel these parents accurately and with some empathy. So this is you've got your scoring, and then after 9 months you can see whether what they will do. And so identify cerebral palsy at 3 to 5 months. Now, cerebral palsy is one of the most prevalent neurological motor difficulties or disorders globally, and particularly in Pakistan we see a lot. It also predicts the gross motor function classification level. If you're not familiar with that, there's a lot of resources, and I'm very happy to take any emails asking me anything about this presentation later on. It also predicts whether they will sit independently or walk. And most importantly, it will catch the mild hemiplegias, which are often not diagnosed and not referred until maybe 2 years of age, when you notice that the fine motor ability of the child is not up to scratch, or that they have some anomaly in the way they move. The third, I beg your pardon, let's just go back to that. The third recommendation was the imaging. Now, I'm no expert on imaging, so I'm not going to try and explain this, and I don't particularly use it in work. Remember, I'm more interested in function as a physiotherapist than structure, but certainly neonatologists, paediatricians need to know exactly what the lesions are in case there is anything that needs to be addressed. And also it gives you an idea of what to expect. However, if you are really not familiar or not very good at understanding the MRIs or interpreting them, there's a very good resource on the surveillance of cerebral palsy in Europe. And again, if anybody's interested in that, I'll give you the link to that. And so when they did these pathways, when they did these recommendations, they also gave us pathways. And I'm not going to go into those in details here. You can find them on the Cerebral Palsy Alliance or at the GMA Pediatric Journal site. And again, I have these. If anybody wants them, please email me directly. But whatever route you take, whether it's high risk, definitely at risk, unclear, definitely not CP, everything leads to arrange early intervention and, most importantly, parent support. You heard what the fathers say. They try everywhere to get help and they can't. So this is another of our role in early intervention. Many of you won't be able to do the GMA at the moment because of COVID, getting to these training sessions in Europe or North America, or actually Turkey's doing them now, so that's much easier for Pakistanis to get to Turkey. They're doing them in Ankara and Istanbul. But if you can't do this and you haven't got anybody, as far as I know, there are 4 people in Pakistan trained at the basic level and 2 in the advanced. Myself and a colleague are doing the advanced, and one of my staff is also basically trained. But that's, I think, all there is. If there's more, I'd love to meet them. So please email me if you know of anybody else doing GMA. The HINE you can learn online. There are very good videos. And this is from the Hammersmith Infant Neurological site. If you just look them up, you will find them. You register, they allow you to use their videos to train, and they have all the score sheets available for you. It's free, which is what I really like about the HINE. Most things have a paywall barrier. But if you haven't the inclination, the time, the will to do GMA and HINE, you can screen by 4 months for red flag issues if you're not using those tools. So that, you know, even if you don't have this specialist training, there are other ways. So a good history, here is the motor questions, but these also exist for social, behavioral and language. So you will, particularly at the moment, there's a lot of interest in autism. I see very little interest in cerebral palsy, which is tragic, but there's a lot of interest in autism. I think it may be easier to set up schools than it is to set up therapy centres. However, if you do a good history, you will find, I'll let you just browse through this, you will find things that may worry you that you can then send them on to early intervention. And then physically you can look for these particular signs. So persistent fisting of hands past 4 months, persistent head lag. These are the things, early handedness before 12 months, a tightness in the legs, a child who's nappy or whose hygiene is difficult to manage because they're crossing their legs or going into spasm. And now I like this video because, and it's just an abridged video. These videos are about 15 minutes long. They're available on thepathways.org. So if you can see that, they're available on pathways.org, and you can view these, and it will do 2 things. It will let you, just going to pause that. It'll do 2 things. One, it'll show you what is typical and atypical. The other thing is it will help you enhance your observation skills. So for young paediatricians not familiar with watching or observing or handling babies, this is particularly a good one to look at. And the Pathways site is very, very active with huge amount of advice for early intervention and parent coaching. I'll let you listen to this.
4-month-old typical atypical motor development side by side. In this video, you will see a typically developing baby and an atypically developing baby in 8 different positions. Use this to help recognize early motor delays. please remember to adjust for prematurity. Position 1, supine, head and body position. The typically developing baby on the left is able to hold his head in midline and has symmetry of the head, eyes, arms, and legs, while the atypically developing baby on the right has asymmetry of the head and extremities. His head is tilted and body curved like the letter C. Presented a toy. When baby on the left is presented a toy, he shows visual engagement, reaches against gravity, and explores toys with both hands. The atypically developing baby on the right is not visually engaged. He does not track the toy. He does move his arms but does not lift his shoulders off the surface. Extremities. Notice the typically developing baby has frequent anti-gravity movements and extremity movement disassociated from a stable trunk, while baby on the right has random movements and not much anti-gravity movement. Position 2, side lying, head and trunk. Baby on the left is able to lift his head and upper trunk off the surface in preparation for independent rolling. Baby on the right cannot lift his head and upper trunk off the support surface. Posture. Notice typically developing baby on the left can sustain this posture with a balance of trunk flexor and extensor muscles, while baby on the right is unable to sustain this posture because he lacks balance of trunk flexors and extensors. Extremities. Baby on the left is able to use upper arms and disassociated lower extremities to assist in facilitated roll. Baby on the right exhibits sluggishness in his top arm during the facilitated roll.
Excuse me. So there, as I said, there's a lot more videos to see, but this is not the place to show you. If you do email me, could you tell me what you're specifically interested in, and I can send you resources. I beg your pardon. So we go on to the next. Okay, just to sum up then, please refer as early as you possibly can. I start in the NICU wards, oh goodness me, I start in the neonatal units when the children are sick or have problems. So be vigilant. Often you see children who are sick and treat that, but then ignore the disability. Please don't do that. Ask the questions of the mother. She'll often know there's something wrong before you do. And really, this is the good history bit. Assess holistically and thoroughly. In 10 minutes, you can do a huge assessment. You know, I know you have very, very busy clinics, but really 10 minutes? Help develop your early intervention services. There are many resources. Now, this is probably the most important point. When you refer, where are you referring to? And do you know what that service is doing? You need to support them, and you need to give them the encouragement to learn modern, or should I say best evidence early intervention services. We as physios and OTs and speech therapists now do not do, passive stretching and movements, and children don't cry in our departments. So please find out the service that you refer to, what are they doing? And then encourage them. This isn't taught in universities, so I've just done a 3-hour workshop, and that was just scratching the surface of what people might want to know. So just to finish off then, this is my contact and our centre's contact. I am not in Pakistan at the moment, but will be very soon when I've had my double vaccination, inshallah. And thank you very much for listening. This is really important because what happens to a child and a baby changes what happens to them all through their life. And if they get a better start, this is less of a burden on the family, less of the burden on the society, and you have done something that will change lives for the better. Thank you very much.
Thank you so much, ma'am. We cannot pay back for what you are doing for our people. For me, it's always very difficult to deal the pediatric population, but you are doing it with all the zeal and interest, and we cannot make any comparison with you. Thank you so much, ma'am. Now, after this informative session, we will move to the next session, that is the fifth keynote by Dr. Anderson Olivera. Dr. Anderson Olivera received his PhD in Biomedical Sciences and Engineering from Aalborg University, Denmark in 2013. His PhD studies involved understanding and improving postural control during walking, during perturbations to the balance. Dr. Olivera conducted a postdoctoral period at the University of Michigan, USA, working on the assessment of electrocortical activity during walking. He has been working as an associate professor at Aalborg University since 2017, publishing more than 50 peer-reviewed articles in the different journals. Dr. Olivera's contribution to the physiotherapy field are evident on studies describing neural adaptations to balance training, studies proposing auditory feedback as a method to reduce vertical loading during running, as well as the effects training and rehabilitation on cortical control of walking in Parkinson's disease patients. He is currently working on several projects, such as creating methods to assess running mechanics outdoors using wearable technologies, the construction of novel methods to assess hip and joint torque simultaneously in football players, as well as developing novel methods to assess motor unit recruitment properties using surface electromyography. Dr. Olivera is a member of the International Society of Biomechanics and International Society for Electromyography and Kinesiology. He has served as ad hoc reviewer for more than 25 international peer-reviewed journals in the field of biomedical engineering, neurophysiology, biomechanics, neurosciences, and sports sciences. Moreover, he is an associate editor for the journal Frontier of Neurosciences. Now, the topic for the fifth keynote speaker of this plenary is Beyond Force Platforms, Assessing Running Impact Properties Using Footfall Sounds. For this, please welcome Professor Dr. Anderson Olivera. Thank you so much.
Good morning, good afternoon to all attendees to the third International Conference in Rehabilitation Sciences. My name is Anderson Olivera, and I will be presenting today some research related to high-density EMG decomposition in dynamic contractions. I would like to first of all thank the organizers of the third International Conference in Rehabilitation Sciences for the invitation, and I hope you all will have a very nice time watching these presentations related to different aspects of rehabilitation from different renowned researchers. So I will start by showing you some images from Denmark. So I am a researcher at Aalborg University that therefore live in Denmark. And it is a very small country, but it has beautiful scenes, as you can see in the pictures, and a very welcoming people. So I would say you should visit Denmark if you have the chance. And of course, I extend the invitation for you to visit me at Aalborg University so that you can see our work and also interact if you want to do some kind of collaboration. Regarding the presentation itself, we will start talking about what is EMG and how and why EMG is relevant for physiotherapy, and then talk about some interpretation of the global EMG data in relation to motor unit behavior. So there are two aspects on how you can use EMG data. And then I will get into the main part of my talk, which is new trends in surface EMG, which is related to the decomposition of signals recorded during dynamic contractions. And then finally, I will talk about some perspectives on how to use this technology, how to use these methods in rehabilitation sciences. So some directions and also some limitations. So we can start by showing you a video of what is actually the EMG recording. So by using, for instance, bipolar configuration, you can stick some electrodes on the top of the skin, and you can record signals that are electrical impulses from the muscles that are active underneath the electrode. So during a cycling experiment, for instance, you can see that the bursts from the muscles that you use by pairing them and having a reference, in this case, for instance, for the tibialis anterior and the vastus lateralis, you can have the signals that show the bursts that will be related to the increasing activation of both vastus lateralis and tibialis anterior. So the greater this signal, it's believed that the greater is the muscle activation. So we can make this parallel of higher EMG being related to higher muscle activity. Then, how we actually interpret the signal. So the origin of EMG comes from a signal that is traveling through a motor neuron that is going to reach a muscle. So the motor neuron and the muscle fibers that is being innervated by this motor neuron compose what we call a motor unit. And in the motor units, you have different pulses. So the signals from the central nervous system are traveling through this motor neuron, and every single trace that you can see in this figure is a signal from the central nervous system for the motor unit to fire. And then the signal is going to travel through the muscle, and by using this changing action potential, we have fibers that will be contracted. Okay, so what we get from the EMG is the shape of this signalization from the motor neuron to the muscle to actually being active, which is the oscillation in voltage of your electrical impulse. So the shape of this impulse is what we call motor unit action potential, and this is the basis for all the recordings that we do in EMG. Then, if you have different motor units, for instance, in this case, we have a motor unit number 1, motor unit number 40, motor unit number 80 in this figure, and each one of these little traces for each one of the units is one firing event. So you can see that motor units may have different firing events depending on their function and depending on their innervation. And each one of them will have a different shape for their motor unit action potential. What we do in EMG is basically to summarize all these signals into the shapes that we see on the screen when we record the EMG. So an important aspect of EMG is that it's the summation of the activity from all the motor units that are being active underneath the electrodes that we record. And this also can be done by using intramuscular EMG, but this is not the topic of the talk today. But just a take-home message from here that the EMG is the summation of the different motor units being recruited underneath an electrode. Then what is important about it? You can see in this figure from a very recent paper that the number of publications related to EMG has been growing. So from the 80s, when the technique started to be actually more popular, all the way to 2015, where we have a new book from Merletti Group and Dario Farina and Barbero. So at this point, you can see that there is a very high increase in the usage of surface EMG specifically because of the popularity of the method, and somehow the technology got easier to be used. So we do have a much greater intention and a much greater interest from researchers and also physiotherapists in how to use surface EMG. So my point here today is actually to show one technique, one of the ways that we can use EMG for rehabilitation. And then what we have been doing, especially for surface EMG, we have been using this to understand the muscle activation during sports performance and training adaptations, also for clinical assessments of injuries pre and post training, and also on the course of a clinical assessment. And one of the techniques that we can use is also neurofeedback, showing the person what is their muscle activation and try to actually teach them to change the way their recruitment happens. And one of the most advanced ways of using surface EMG is actually the use of myoelectric control for prosthesis control. So we have some projects related to this, and it's amazing how you can use activities from the muscle that is remaining on a limb that has been impaired, and you can actually drive the usage of a prosthetic limb for functional tasks. So it is a very rewarding field to work on because you can see the practical usage of EMG in the daily lives of people. So there is a scope of intentions where EMG falls very well, where physiotherapists actually want to understand how the motor system, how the central nervous system is actually recruiting muscles, and we want to understand how these muscles are behaving. If there is change in the way that the muscles are working, we should actually intervene and we should make this muscle activation better so that the person can be more active. So we can use EMG for many, many purposes in this way. But there is a problem then, because the way we use EMG may be misleading, and in my presentation now, I'm going to talk to you a little bit about what is the common sense about EMG usage and what is actually EMG in terms of interpretation. So in here I show you a single plot where I have in one axis the EMG activity and another one the muscle force. And this line here may be an interpretation that the greater the force that you want to generate, the greater the EMG activity, the greater the signal from the EMG we record. And to increase the EMG activity, we may have two different strategies. So to increase the force or the torque level on a certain joint, we may have to change the recruitment strategies of a certain muscle, which may be related to the number of motor units being recruited. And in another hand, you can also use the rate coding, so related to how the motor units are working, if you have to increase or reduce the discharge rate of these units as you actually recruit. So as an example here, we have a raw surface EMG signal from an isometric contraction for the ankle dorsiflexion, so there is no motion, it's an isometric task. And you can see that the signal goes up and then gets stable and then it goes down. By looking at this, we can say that the muscle is actually increasing activity, but we don't know exactly which one of these strategies we have been using. We don't know if it is only the motor unit recruitment strategies, if we're increasing the number of motor units being used over time, or if you're actually increasing the rate coding or the discharge rate of the units as you actually increase the force. So this is the force trace for this contraction, and you can see a steady increase, and then a stable period of a plateau, and then it goes down. So if we just look at this surface EMG, the conclusion we can take out of it is that we have an increased muscle activity, but we don't know exactly how you increase the force. So by using the composition of surface EMG signals, we can see that, for instance, the traces that you see now on the screen are actually motor units. So the discharge rate of the motor units over time. And then on the y-axis on the right, you have the torque levels. So in here, you can see that the low threshold units will be recruited earlier, and then they will increase the discharge over time as you actually increase the force level and then get steady. In the same way, you will have the high threshold units being active later in the cycle because they actually are activated in a higher torque level. They need to be used only in higher torque levels, and the discharges is smaller than the low threshold units, but eventually you can see that both motor units and recruitment strategies and both rate coding and also rate coding are used in this contraction for both the increase in the force level and also the reduction in the force level. So it is a much more detailed way to describe how the motor units are being active during muscle contraction. So just to emphasize here that the global measures that we get as recording, for instance, bipolar EMG, they are a simplification of what's the neural input to the muscle. If we use the motor unit properties, we will have an accurate estimation of what is the neural input from the central nervous system to the muscles. And this is a very important step forward in understanding how rehabilitation works, because we can actually say what is happening to the input to the muscles as the rehabilitation process, in terms of physiotherapy, of course, is occurring. So another example here is a bipolar recording as a person is performing a task to failure. So imagine that you're doing a fatiguing exercise, an isometric task, until failure. So in this recording here, you can see we have 300 seconds of contraction, about 5 minutes and a half in this case. And over time, the muscle, tibialis anterior in this case, is increasing the activity all the way over time. And in here, we don't know exactly what is the strategy that has been used. So we don't know if there is an increase in the number of units being recruited over time, or if the same units will be increasing their activation over time. Then what has been shown recently is that the discharge rate over a period of time that has a fatiguing task, so in this case only 120 seconds from Martinez Valdez in 2020, they show that the actual discharge rate in the first phase of the contraction goes down, and then it goes up after in the second phase. So there is a biphasic neural drive strategy to actually comply to a fatiguing task. So if we conclude by looking at a surface EMG signal globally that we have a steady increase in the muscle activation, this may not be true because the discharge rate of units may actually be decreasing in the first half of a task to failure, and it's then increasing afterwards in the second phase. So we need to be careful when we use surface EMG in order to make conclusions on how the central nervous system is modulating tasks, and for physiotherapy, for rehabilitation, also for gait analysis and other types of activities. This is crucial to understand whether or not we are communicating the correct information to people. So the main issue with EMG is specifically for being very detailed about what is the motor unit behavior, is that when we do isometric contractions, we do have a relatively stable muscle length. So if you see this person performing a half squat, the length of the quadriceps muscle, for instance, or the biceps femoris, the hamstrings, they will be somewhat stable. And because of this, you have a low stationarity. And the stationarity is, in this case, the ability of a certain pattern of a motor unit action potential to stay the same. And another important point is that you don't have a lot of shift between the muscle position in relation to the electrode on the top of the skin. So this actually makes much easier assessment of the EMG, and also because you're doing an isometric contraction, you can also easily perform an evaluation of the force output, for instance, using dynamometers or load cells, strain gauges. It is a lot easier to understand what is happening in isometric contractions. We have known for a while that even isometric training for rehabilitation can be useful, but I don't think this replaces rehabilitation based on functional motion. And when you think about a functional task, for instance, a squat, in this case, you can see that you have a much greater change in the muscle length. Imagine that the muscle has to contract, it has to shorten, it has to lengthen as you actually do a movement on this wide range of motion. And this brings you non-stationarity of the signal. And this is the biggest roadblock when we want to talk about EMG in dynamic contractions. So you have a lot of electrode shifting in between the muscle and the electrode, and the force outputs that are generated is extremely complex. So there is a lot of influence of the task itself on the EMG recordings, especially if you want to decompose EMG for describing motor unit behavior. So just to illustrate a little bit how this issue is presented to us, if you record the data from electrodes on the top of the skin, and the central position of the muscle changes in relation to the electrode grid, you can have changes as described by Guimarães and other authors. That is, the amplitude of the EMG over time will change depending on your muscle length. So this is the length of the tibialis anterior muscle in different angles, so 55 all the way to 130 degrees. So the change in the angle of the joint will change the shape of the motor unit action potential. And this is the biggest limitation that we get when we want to decompose data from EMG, simply because the shape that you want to track over time will change because you're changing the length of the muscle. And it can also change because you're changing the force applied as you actually do the motion over a range of degrees. So we have this major limitation to extract accurate descriptions of motor unit behavior from dynamic contractions. And this will be irrespective if you're using EMG from intramuscular settings, which is straight wiring the muscle with an insertion of a needle or a wire, or if you're using surface electrodes on the top of the skin. So in this way, what we know is if we do recordings in isometric contraction, you can have beautiful curves of increasing stable and reduced torque, and you can describe the population of the motor units very well with a certain degree of accuracy. If we do this for dynamic contractions, we have only a few studies actually presenting how this can be done. And one of the first studies being describing this kind of technique was the Luca in 2015, showing, for instance, cycles of biceps brachii flexion and extension. So you have the muscle length changing as you actually raise a certain load. This is the raw signal for the EMG, and these are the 10 motor units that they are describing over the concentric, eccentric, concentric, and eccentric phases. So this was the first experiment that was showing that this could be possible. There might be some limitations on the technique that they use, but this was a very important breakthrough in this area. But now what I would like to show is how we managed to do some kind of recordings like this as well. In a recent article published by me and Francesco Negro from the University of Brescia. So in this study, we actually evaluated the change in motor unit behavior during muscle lengthening and shortening in increasing velocities. So the idea on this manuscript was to understand if you have to change the velocity of your movement, how you manipulate, how you modulate the control of these muscle recruitment. So we don't know exactly what are the other strategies to perform actions at different velocities or speeds. And what we wanted was to evaluate whether we could determine what are the changes in this neural control of muscle shortening and lengthening by tracking the units in different contraction velocities. So what we did was to ask people to perform a task on a dynamometer. So this is the task in a slow velocity. So this dynamometer, we have a tibialis anterior action, so ankle dorsiflexion, and there is a constant torque. What the person has to do here is follow this path that you have in the purple area. So these lines are actually making a path that the person has to follow in the concentric, isometric, and eccentric phases. And they do several cycles of this task as we record high-density EMG from the tibialis anterior muscle. With this technique then, we did ask them basically to perform this task at 5 degrees per second in the concentric and eccentric phase, and then in another trial to do this at 10 degrees per second in the concentric and eccentric phase, and in another cycle, in another phase, to do this at 20 degrees per second in the concentric and eccentric phases. Okay, so we had two loads levels, 10% of MVC and 25% of MVC, and we recorded then 64 channels in this study from the tibialis anterior, and decomposed this using pre-established methods for blind source separation of the action potentials. By tracking these action potentials from these different recordings, we could see whether or not the same shape of action potential was present in the three conditions, and then we could successfully say that we tracked the motor units in different conditions. So here I can show you an illustration of how the decomposition looks like by the end of our analysis. So in this plot, I will pause quickly here. In this plot, you have in the y-axis the dorsiflexion angle, so from a position that is plantar flexed all the way up in the dorsiflexion. So this gray line is our angle, and then the line at the top here is the ankle joint torque. All these colored lines are different motor units, so each color is a motor unit, and you can see we have 17 motor units. And over the course of the trial, this is a 10 degrees per second trial with 25% of MVC. So in here, you see that you get the activation of the motor units following the angle. So the greater the angle, so the shorter the muscle, the greater the number of units we use. And also during the eccentric phase itself, there are units that will be increasing their discharge rate over the course of the contraction. So you have both strategies here by increasing the number of units being active and also increasing the discharge rate of the active units to control the concentric phase. As soon as we reach the concentric plateau, as soon as we reach the isometric phase, you can see that some units also derate. And during the eccentric phase, they start to derate and in an orderly way if you compare to the concentric phase. So the units that are recruited earlier in the concentric phase, the low threshold units, are the ones that will be de-recruited later in the eccentric phase. In the same way, the units that are recruited in very high length positionings, in very short length, shortened muscle lengths, are the ones that will be de-recruited first. So we have this important aspect of the contraction, that is basically you have to use this as you have to control the muscle position more than the torque itself by using different motor units. So on another example here, we have then a matched analysis. So we have units that are one unit at 5 degrees per second, another unit at 10 degrees per second, another unit at 20 degrees per second. The points here are the discharge rate over time, and you have the concentric data in blue and the centric data in green, in pink. And we can see that the unit has a very, very standard way of behaving. Regardless of the speed, it is continuously firing. And the greater the velocity, you can see that the greater is the inclination or the slope of your concentric discharge rate. So what we did was to compare the slopes of the concentric and the centric data, and we could see that the slopes for the concentric phase are much greater than the slopes of the centric, which is expected. And within the velocities from 5 to 10 to 20, you have a much greater increase for the concentric phase in comparison to what we see in the centric. And this happens for both 10 and 25% of MPC. So this means that you have a greater increase in the neural drive during concentric phase, and you have a reduction in this neural drive in the centric actions, even though you may be in a faster contraction type. Then, another part of our illustration here is to show how these units behave as you do have a matched comparison. So in this video, I show you in blue motor units that are continuous, and the same motor units at 5 degrees per second, and at the bottom at 20 degrees per second. And in pink, we can see the intermittent motor unit that does not fire the whole time, and it doesn't fire the whole time also if you're doing the contraction at 20 degrees per second. So we do have, in this case, an evaluation that will, we have in this case an evaluation that will show us that you will have a maintenance of the property of this motor unit if you are changing conditions. If you're going from 5 to 20 degrees per second, it is likely that the units that are firing intermittently, they will remain firing intermittently, okay? And also the recruitment of these units will change depending on the speed. As we can see here, the recruitment threshold is related to the angle of the joint, not to a force level. And the greater the velocity, the lower is the angle of recruitment. And this means that the muscle has to recruit the units, the central nervous system has to recruit the units earlier in the cycle to actually make the contraction to happen in the faster velocity. So this is very important because this can explain why you get a greater EMG in the faster velocities, because you're starting to recruit earlier and the increase of the discharge rate is actually more pronounced in the concentric action. So with all of these in mind, the conclusion of the manuscript was that we could successfully track motor units recruited during dynamic contractions during low and moderate velocities. And the faster velocities will require greater variation in the neural drive, meaning that we have to have a greater steep slope to drive the motor units in the faster velocity. And finally, this contraction velocity would be more related to the contraction strategy related to rate coding, more than the recruitment of new motor units, as described by the earlier angle of recruitment in the faster velocities. So how can we use this information from high-density surface EMG in the clinical settings? My first idea here is to describe the motor unit's recruitment patterns in functional actions. So if you do have a rehabilitation procedure that requires walking, that requires sitting and standing, that requires one leg standing, we should understand how the rate coding of the task that you want to evaluate actually is in terms of motor unit behavior, and also understand whether or not, if you are performing a clinical assessment, if you do have a very unstable rate coding. And this also comes through the idea of understanding the variability of these motor unit discharge properties. It is possible that people with tremor, that people that have, for instance, difficulties in knee stability related to patellofemoral pain or ACL injuries, we may have functional dysfunctions related to the motion, mostly because of inconsistencies in maintaining the drive to the muscle. And this may be related to the variability. So we can talk about interspike intervals of motor unit discharge to actually understand how the neural dysfunction is actually behaving in this person. And then finally, actually tracking these units, if possible, throughout the rehabilitation protocol. If you can track the units, you can see whether or not the same unit is actually behaving in a more proper way if you consider that you need stabilized interspike intervals, you need stabilized rate coding to actually perform a task that you are teaching or that you are proposing in the protocol, in the rehabilitation protocol. So it would be very interesting to generate an accurate assessment of the neural control. And this can be a very practical way to understand if the rehabilitation protocol is working, because you can see the movement getting better, but you can also have a certainty of the central nervous system improvement also in generating the correct neural signals to the muscle. But there are limitations to this type of evaluation, and I will pinpoint 4 of them in these last slides. The first of them is the lack of professionals trained to use this method. It is a very complex way of evaluating data, is a complex way also to record data. So there are not a lot of professionals in the physiotherapy field and also clinical fields in general trained to use this kind of technology. And also the cost of both the equipment and the maintenance of materials may be still high to compare to the benefits of using low-level technologies like bipolar EMG, or even just by talking about palpation to understand if a muscle is actually being recruited. So the cost may be a driving point here to actually prevent researchers in the physiotherapy field to use these technologies. Then the data recording procedures itself, they may be time consuming. So if you consider making an evaluation like we did in this manuscript, it may take time to prepare the electrodes, may take time to put the electrodes, check if the signals are okay, and then recording the data. So all this process is time consuming. And sometimes in physiotherapy, we don't have so much time to actually be with the patients. So this is one of the limitations, that we need to make the technology to be even easier and faster to use. In this term, we have electrodes that are dry technology, so we don't need to put any gel, we don't need to put anything on the electrode, just stick into the skin and then use it. So this could be a way of doing it. And then finally, we have the data processing itself. So the way that we analyze this data is not user-friendly. And unfortunately, we still have to make a lot of adjustments, a lot of improvement on how the information goes towards the clinicians, so that you can actually use this information and also understand how to derive your own analysis. So we still a long way before we can say that this is a user-friendly method, but we are working on improving the technology and improving the data processing methods to make it easier for understanding and easier for using in terms of practical applications. So with this, I'm finished. I would like to thank you again for joining my presentation, and I will be happy to answer the questions if you have any during the question and answer session later on. Thank you very much and have a great day.
Okay, thank you so much, Dr. Anderson, for such an informative talk with us. Now we will move forward to the last keynote of today's session, that is from Dr. Douglin Jackson. She has served in leadership roles in American Occupational Therapy Association, American Occupational Therapy Foundation, Florida, Occupational Therapy Association, and Autism Society. She holds a PhD in special education in early childhood. She has various professional certifications, including assistive technology, telehealth, sensory integration, and health and wellness. Dr. Jackson has 20 and plus years of experiences in the rehabilitation field, primarily with individuals with neurodevelopmental disabilities across the lifespan in schools, hospitals, clinics, and community-based settings. She has worked in academia and is an experienced researcher, having written grants and been awarded funding. Her research interests include health and educational disparities, social equity, autism, early childhood, telehealth, and assistive technology. Dr. Jackson provides consultation, professional development, individual and group therapy, and advocacy services through her practice in Gifts Institution LLC. The topic for the 6th keynote speaker for this plenary session is Framework across disciplines for telehealth intervention. To present that, please welcome Dr. Douglin Jackson. She'll be live here with us. Over to you, ma'am.
Thank you for that introduction, and let's get started. So our objectives for this session are to first discuss a framework for telehealth implementation across the lifespan, explore practical strategies for telehealth intervention, and identify practitioner considerations for effective telehealth intervention. And I'm Dr. Douglin Jackson. I'm happy to present here with you all. And what we'll be looking at is an overview first, then moving on to telehealth intervention. And then we'll talk about self-care for the rehab practitioner, and then move on to closing out this session. So let's get started with a quick overview. So telehealth is referred to by many different names: telemedicine, teletherapy, telepractice, telerehab, and you can add on many different suffixes to the end of tele, depending on your discipline. In much of the healthcare industry, the terms telehealth and telemedicine might frequently be used interchangeably. This might be confusing to some, as the definitions encompass very similar services, including medical education, e-health patient monitoring, patient consultation via video conferencing, health wireless applications, transmission of image medical reports, and many more. But telehealth is a collection of means or methods for enhancing healthcare, public health, and health education delivery, and to support using telecommunication technologies with our clients. Now, whether you've been working in telehealth for a while, just getting started, or consider yourself an expert, we all have those moments where we might feel stuck, overwhelmed, or just need a little direction. Many might have had a prior interest and been an early adopter of telehealth. Others might have been thrown into telehealth during the pandemic, and you might have figured out the technology already after either getting ready to conduct your first session, or maybe have given a few sessions, and you're now probably trying to figure out a better approach to streamline your intervention. Emotionally, you might even be having mixed feelings about telehealth and apprehension, anxiety, or even apathy. But we want to be sure we get beyond that and get you moving towards the things that matter so you can be more effective. Now, when it comes to telehealth ethics, we all have an obligation to establish competency when providing interventions. Telehealth isn't new and has been around for a few decades. It's important to consult the guidelines of your respective practices and ensure that you're practicing within those guidelines and building your skills to be effective in the virtual environment if you aim to or are providing telehealth services. Now, my telehealth story started back in 2015, where I was working on a community-based grant and was asked to teach telehealth to various professionals. These included speech therapists, behavior therapists, those working in early intervention, as well as occupational therapists like myself. I've also provided professional development where I've taught others through online learning, and I've moved into conducting research for best practices for telehealth and quality improvement. I want you to consider where you see yourself as a telehealth practitioner, whether you're a novice with no experience or just getting started. You might be a beginner, have provided a few sessions. You might consider yourself even proficient and have developed skills in this area, or an expert where you're skilled in telehealth service delivery, but always remember that there's more to learn and that technology is always changing. But remember that telehealth goes beyond the technology. And that's what I want to share with you all today. So it starts with your mindset. Those of you who might be apprehensive, experienced, or even an expert, your mindset plays a key role in how effective you'll be with telehealth service delivery. And if you look into research, there's so much going around when you look in professional business literature where it talks about mindset. And I like to break it down into the ABCs, your attitudes, behaviors, and change when it comes to mindset to then move into practical approaches to telehealth service delivery. So if we look at attitudes, you have to consider whether you're feeling defeated or if you're hopeful and even open-minded. It doesn't apply only to you, it applies to your clients too. When we think about the behaviors, are you prepared for your sessions? Are you intentional in your approaches? Are you supportive of your clients on the other end who might not be willing or apt to want to participate in telehealth? And then above all else, you have to work towards creating that change in your mindset as well as that of your client. For the practitioner, you have to have buy-in to fully embrace the possibilities with virtual service delivery. For the client, they also have to have buy-in and be motivated to participate in the virtual sessions, because above all else, we want to improve their outcomes. So you want to stop simply doing telehealth and build your competency in this area and learn how to systematically provide telehealth services. And I'll quickly go over a framework for you guys as I get some other things out the way. So once you address your mindset, that attitude about telehealth, your behaviors, and create change, you're on your way to being able to administer effective telehealth interventions. And I want to help you find that telehealth joy just like you have when working in person with your clients. So shift your mindset and continue to work on improving your competencies in telehealth by seeking professional development and building your community of colleagues and resources. So let's talk about telehealth intervention. I'll provide a quick overview and talk through key components of intervention across the lifespan. So no matter what discipline, age range, or setting you work in, this information will be applicable to you. The Coalition for Telehealth in Behavioral Sciences was formed in 2014 to start a division of the American Psychological Association, and we found that these strategies can apply interprofessionally as well as internationally, as it helps us to understand the role and competencies of teleproviders. Under the subdomain of evaluation and treatment, they identify 6 key components for service delivery. You want to assess for client appropriateness for services. You want to assess and monitor client comfort with those services. You want to apply and adapt your in-person clinical care requirements to the telehealth environment. You also want to implement and adapt a service plan with policies and procedures adjusted accordingly. You want to monitor therapeutic engagement related to each modality that you use. And you want to provide training, supervision, as well as consultation to others who might be involved in the telehealth service delivery process. Also pointed out was the need to consider diversity and culture with telehealth. Cultural competence and diversity related to telehealth is defined as applying principles relevant to professionals making ongoing efforts to understand the manner in which cultural, linguistic, socioeconomic, and other characteristics related to diversity impact the therapeutic engagement, assessment, triage, treatment, and outcomes. Clients, patients, and professionals reflect on cultural commonalities and differences. Cultural awareness, humility, and sensitivity help to engage clients and patients, as well as facilitate expression, reflection, and participation in care with attention to their cultural identity, their explanations when it comes to the models that we're using, how they may help and seek out care, and their preferences for care even. Now, assessment, triage, and treatment may have to be adjusted when moving from in-person to telehealth, and it's important to assess the language preference and skills to optimize communication and determine whether you might need an interpreter or not. So practitioners need to consider assessing for cultural factors influencing care, ensuring communication using the client's preferred language, and creating a climate that encourages reflection and discussion of cultural issues in an ongoing manner. Now, when it comes to telehealth, we often focus so much on the technology. With the practitioner, you want to consider your device. Are you using a laptop? Are you using a phone? Do you have good internet connection? What's your camera? Do you have multiple cameras, even a document camera if needed? How is your audio? Can you amplify it and adjust it? And a monitor, can you see the different things that you need to show your clients and have a second monitor to be able to organize them? And above all else, what platform will you be using? Depending on your country, it might need to be more secure than others. You need to check into the regulations regarding privacy and be sure that you choose a platform that affords that opportunity and stays within those guidelines. With the client, do they have access to devices that can connect for the sessions? How is their internet? Are they using Wi-Fi or are they using cellular data? Do they have a camera where you can see them and they can see you? How is their audio? Do they have hearing impairments? And do you layer on other assistive technology to support those needs? And if there are any supplies that might be needed to conduct the session, do they have access to those in the home or whatever environment they're in? Or are you able to provide them with that? Also, when it comes to sessions, we need to remember that telehealth is considered face-to-face. And we need to determine how our sessions are going to be structured. And you're not limited to just one version. You have to weigh the benefits and limitations of in-person versus virtual. With the stratified approach, it's predetermined where you're either having in-person and virtual components and what order that might be. With a hybrid approach, it's a combination and it's a bit more fluid. And depending on the parameters of which you have to operate, you may be relegated to only virtual sessions. So remember that you're not limited to just one, you can have a combination of them. Now, telehealth services begins with the initial assessment, and it includes the process needed to provide intervention, and then culminates or continues with the reassessment of outcomes and concerns. When we're looking at assessment, you want to see if you have consent. Do you have your intake forms, and can they be completed virtually? Can you conduct all components of your evaluation virtually? And then develop your plan of care when we're looking at assessment. For the setting, where are these things taking place, the time, the location, what resources are available, and can you have a session prior to your initial one to help test their connection and get them set up? When it comes to outcomes, do you need to revise the initial short-term goals or long-term goals or develop them with telehealth in mind? For intervention, what materials will you be using? What approaches will you be using? Are you coaching? Can you be hands-on using a hybrid approach when needed? For monitoring, you reflect after each session. You may need to set up home activities. And also remember to plan for your next session. And then reassessment, which is ongoing, and you refer back to your plan of care. Now, some approaches that are often used in telehealth include coaching to begin with. And if you look into the early childhood literature, there's lots of information on coaching. In occupational therapy, we have occupational performance coaching also, as well as cognitive orientation to daily occupational performance, where it's very client-centered and you're focusing on those things that are identified as a priority by the client, because we always want to be client-centered. When we're looking at materials, are you able to mail a kit to the clients? Are there household items around? With your assessments as well as your intervention, what materials are going to be needed? When you're choosing your platform, can you screen share? Is there a whiteboard? that you're going to be able to use and maybe write together. There are apps that are out there now that you can use and share the screen so that you and the client can engage. And also when we talk about cameras, can you demonstrate and move away? If you're doing physical therapy and lots of movement, can they see your entire body for demonstration? And can you see their body for safety purposes? Therapy doesn't take place always at a table. And we need to remember that we can move away. So think about your camera setup and can you see their full body? Also, we want to consider the environment. Can you go outside? Are you in the kitchen? Are you in the bedroom, the living room? Where is there a safe space to do that? You want to be able to see function in different areas of the natural environment. Then there's problem solving. Take time to discuss the strengths and successes with the client and enlist them to plan the sessions collaboratively. Then there's support. Is there someone there to support your sessions? Are we looking at the mental health of our clients as well as ourselves? And then self-regulation. Are we checking in throughout that session to see how it's going for that client? Is it too difficult? Do we need to adjust? And then above all else, function. Beyond the activities and exercises that we like to recommend and engage in, can we embrace functional activities to promote engagement, participation, and performance? So I know that's a lot that I stated right there. And the framework that I was getting at is called the START teletherapy framework. And it's something I developed as I was teaching a lot of clinicians and practitioners prior to the pandemic. And that increased even more during the pandemic, where many felt lost and they didn't know where to go and how to compile everything that they've learned prior to being shifted in the telehealth space. So START is an acronym that allows you to remember everything that I just said to provide effective telehealth across the lifespan. So S is setting. What time of day are you providing the services? If someone takes medication, is that going to impact that? The location, where are you providing these services? Are you at a hub, or are you in your office, or are you in your home? What technology do you have? What resources are going to be needed? And can you provide that test session? When we're looking at the techniques, once again, what interventional theory and framework can you draw upon depending on your respective discipline? Are you able to use coaching? What modalities are appropriate for telehealth in that environment? What session type and structure are you using? Is it stratified? Is it hybrid? And will you be providing consultation even through that model? The A is for activities. What materials are you going to need for your intervention, even your assessment? What's laid out on your treatment plan? And then when we look at reflection, you want to stop and reflect on your struggles, your opportunities, as well as the successes during the session. And you do that collaboratively with your clients. And then the T for START is training. Training for the client, training for the caregiver, even e-therapist that's there with you, and training for yourself. And always remember your home activity programs to promote carryover of what you're working on in your session. Now, I have a template that I teach and allow people to use to remember all of this. And if you think back to our SOAP notes, how we write our notes up, the first half you can complete prior to the session based on information you already have, looking at your plan of care, looking at your goals, putting is setting, techniques, activities, reflection, and training. This just helps streamline that process for you all. Now, I would be remiss if I didn't take a moment to focus back on the practitioner. Telehealth isn't all about providing services, as we as practitioners need to practice our own self-care. And I'll go over some of these on the next few slides quickly, but you want to think about fatigue, your ergonomics, your workflow, what training you don't always want to be empty in your sessions or feeling drained. You want to be charging, get recharged and empowered so that you can be as effective as you were in person virtually. So when we think about fatigue to begin with, burnout is real. Screen fatigue. What about your eye health? Are you taking care of that? You hear Zoom fatigue a lot. It also applies to your clients. They're feeling as though they're playing therapists because they're having to do a lot of the work themselves without you being there hands-on. Scheduling, how can you modify that so that they're not overscheduled? And then that Zoom fatigue is real for them. That virtual space can be very taxing on individuals. When we're looking at ergonomics, how are your ergonomics? How can you set up your environment to support yourself so that you're not feeling pain? We've pivoted to create a space so that we can work. What did that look like? Think about that space and whether it supports your body and the things you need to do. So when we think of ergonomics, we're looking at positioning. Are you using a laptop? Are you using a tablet? Are you using a computer? The same ergonomics that we apply to our clients, you need to apply to yourself. I had to have a colleague advocate for a standing desk so that she could get that covered through her work. If you can't get a standing desk, use the books around you to elevate your view, your screen. Figure out where your keyboard needs to be so you don't end up with carpal tunnel and things like that. And do you need special glasses to block out that light? Do you have natural light available to you? What's your seating like? Are you at your kitchen table or are you in an office chair that fits you properly? And the duration of your sessions. Are you able to take breaks? Or are you continuously doing a lot of repetition and work that's counterproductive for your body? And then our workflow. We're always very busy as practitioners. You have to consider your consent forms, are they in place? Planning for your sessions, conducting the session, and the documentation that comes with your session. Can you do that virtually? And if not, what can you do to facilitate that and follow up? Remember, you need to plan ahead. You may need to email your clients. You may need to check in with them at the start of the session to see how things are going. Explain how that session is going to be for that day. And then enlist them in planning the subsequent sessions or even throughout that session, what's working, what's not. Use that time to work your magic and empower your clients too. And then remember, when you wrap up, it's reflecting on those strengths, those struggles, as well as those opportunities to improve with your next session. And self-care. That self-care is very important for each and every one of us. You have your physical self-care. Are you taking breaks as needed? Stretching, hydrating, drinking your water throughout the day, and your eye health. Emotional. Are you managing your stress well and checking in with your mental health? Are you having compassion for yourself and others, including your clients, the caregivers you're working with, and even teachers if you're in the school setting? And socially, have you built a community of practice for those working in telehealth to help support you? There are social media groups that you can find, and hopefully with the profession too. And then spiritually, how are you taking time to reflect? Are you meditating? Are you spending time alone to recharge yourself? Are you journaling and considering what's working, what's not working for you, and being sure to adjust that? So self-care is very important. Telehealth isn't necessarily easy work, and it's not just turning on a camera. You need to put forth the same effort and sometimes even more as you would when in person with your clients. Check in with yourself and make sure you're intentionally practicing self-care. Take a break and step away from the screen occasionally, and be sure to recharge your battery, just as you would your devices. Now, as we move on to concluding, I want you all to remember that you have great skills in person. It's just a matter of translating them into the virtual environment. And there are many things that you need to consider with telehealth. It's much more than just the technology. And telehealth allows you to provide the continuum of services for your clients, from assessment through the intervention process. And looking back at the START model, the START framework is there as a means to develop your clinical reasoning and help you streamline your processes to providing effective telehealth services. And as a recap, that S is for setting, the time, location, technology, resources. The T is for techniques, your intervention approach. A is the activities, the materials, and what you plan to do in your session. R is the reflection, successes, struggles, opportunities, and then training for yourself, your clients, as well as those who are there to support you. So I want to thank you all for having me here, allowing me to share the START framework with you all. We'll close out this session and then move on to questions and answers. And if you'd like to get in touch with me, you can follow me on social media at Dr. Dougleen, and find me on LinkedIn at Dougleen Jackson, and Facebook as well. So I'm going to stop sharing and turn it back over. Thank you all.
Thank you so much, ma'am. It was such an informative and wonderful session. And I'm really thankful to you, despite of so much of the time difference. You have given us the time. It's almost 3:30 a.m. there from where the madam has joined us. Thank you so much, ma'am, for this. After the end of this 6th keynote, I would like to start the question answer session. We have received 2 questions after the session of Dr. Habiba Thawer. Now I'm not sure who can answer this question. I'm just stating the question. Please see who can answer it. Is hybrid sessions physical therapy as effective as manual therapy session, like a patient who is undergoing post-traumatic ligamentous injury and follows a conservative rehabilitation program, or for many other conditions involving musculoskeletal conditions? Please.
I'll chime in. This is Dr. Jackson. Yes, it can be effective, but you have to consider the cognitive abilities of the client. You have to make sure they're well aware of their precautions, and if they need any particular equipment at home that they're going to need. And using a hybrid approach still allows you to have that hands-on intervention when needed, and then they can carry over those activities once they're in their home space.
Okay, thank you, ma'am. There is one more question. It's look like when we can involve in tele-rehab with some traditional physical therapy assessment and techniques, can we involve with advanced techniques of treatments as well?
You have to consider the modality and the limitations when it comes to that type of rehabilitation. Some modalities are most suited for the clinic environment. Some assessments you can only administer when in person, and others you can use virtually. You can track range of motion and things with different apps and approaches using your screen even. So even though you can't be as hands-on, studies have shown that you're not too far off when it comes to degrees of measurement and things like that. So certain things, yes, you can conduct virtually, but others might need to be done in person. So that hybrid approach is best to use, and consider the fidelity of whatever measure you're using if it is tooled for that environment.
Thank you so much, ma'am, for answering the questions. Now I would like to call Mr. Professor Dr. Muhammad Nazim Farooq to give his reviews about the whole session.
Good afternoon, everyone. First of all, I'm very thankful to the organizer of this conference for inviting me to co-chair the plenary 3 session of 3rd International Conference on Rehabilitation Sciences. It was really a very informative and knowledgeable session. The first talk was by Dr. Paul Hodges. He emphasized to identify the primary drivers of the pain and then to develop the intervention according to that. Just he emphasized the right intervention for the appropriate condition to get the better results. Just like, for example, in case of nociceptive, he advocated to consider the motor control development and for the nociplastic to consider the biopsychosocial, the behavioral training and education therapy. The second talk was by Professor Dr. Charles Heger. He drew our attention to the assessment of the sensory motor control in the patient with ACL injuries. The third talk was by Dr. Habiba Thawer. Madam, you have done a good work at Aghan University. She described the efficacy and effectiveness of tele-rehab. So there is need to develop infrastructure if we want to use this tele-rehab in our country, and we need to consider how we can overcome the barriers. The next talk was by Yvonne Friesel. Dr. Yvonne Friesel has done brilliant work as ECI. She emphasized the early recognition of the atypical neurological development behavior in CP and highlighted the different skills required to promote early referral for the early intervention. The next talk was by Anderson Olivia. He described the relevancy of the EMG to physiotherapy and rehabilitation. He also discussed the limitation for using these techniques by the physiotherapist. And the last talk was by Dr. Douglas Jackson. She described the key component of telehealth and different intervention approaches like stratified, hybrid, or virtual. I think it would be a really help to the physiotherapists in Pakistan to develop and start the telehealth here. Now I conclude this session with hope that the knowledge we gained today will have a positive impact on our clinical practice, teaching practices, and the research. Thank you everyone for listening this session.
Thank you so much, Dr. Nazim Farooq, for your worthy words. Now I would like to request Professor Dr. Muhammad Ishfaq Ahmed to conclude the session, please.
Bismillah ar-Rahman ar-Rahim. Thank you so much, Dr. Mariam Shabir, for your wonderful introduction. I'm also thankful to Rifa International University for organizing this very well-needed conference, 3rd International Conference. Thank you so much, Professor Dr. Asghar, Professor Dr. Shakil Rahman, and Professor Dr. Salman Bashir for inviting me as a chair of this session. Today, we have got a wonderful opportunity to go through these wonderful presentations by our well-renowned international faculty members. Like the first one was Professor Dr. Paul Hodges on motor control and musculoskeletal pain, tailoring treatment to individuals. He beautifully explained the biopsychosocial model with lumbopelvic control, also highlighted 3 basic control strategies. He has explained neurobiological mechanism of pain in terms of differential diagnosis, nociceptive pain, nociplastic, and neuropathic. In the end, he concluded with the motor control training, correction of motor control faults by static and dynamic progression, which was ultimately led to functional re-education. The second keynote was Professor Dr. Charlotte Hager on assessment of sensory motor control and consequences after ACL injury. Again, another important topic. She highlighted the significant consequences of ACL injury, important risk factors, also discussed the important components of evaluation of rehab of ACL injury. She also recommended that there is need of biomechanics, but also there is need of sensory motor control also, capturing of movement control with 3D movement analysis, functional test in the movement labs. She showed us so many videos about vertical and side hops. She also shared her research work on a systematic review protocol on psychomotor properties, and in the end, kinesiophobia, that is fear of re-injury. The third topic was from Dr. Habiba Thavir, efficacy and effectiveness of tele-rehab and its impact on patient care. Beautifully explained the tele-physiotherapy and the barriers and the benefits of tele-physical therapy. She proved that exercise-based and cardiac rehab patients treatment is equally effective as face-to-face treatment. In the end, she also presented few case studies. Then Dr. Yvonne Frizzell, early recognition of atypical neurological development, wonderfully explained the general movement assessment scale and Hammersmith infant neurological examination. Then she also highlighted the role of MRI and cranial ultrasound for early referral and for early intervention. Dr. Anderson Olivia again chose a very important and need of time topic, that is high density EMG in dynamic contractions, another perspective for physiotherapy and neuro rehabilitation. He defined the EMG with why EMG was related to physical therapy profession, interpretation of global EMG versus motor unit behavior, highlighted the new trends in surface EMG, and ultimately perspectives of the use of high density EMG decomposition. The last talk from Dr. Declan Jackson, framework across disciplines for the telehealth. She highlighted the role of mindset in terms of attitude, behavior, and change. Telehealth technology, different approaches like stratified, hybrid, and virtual. She also discussed the interventions in terms of coaching material, screen share, and demo. And in the last but not the least, the START model, that is setting, technique, activities, reflection, and training. So as a whole, I found all the presenters wonderful, up-to-date, and very knowledgeable. I hope that our Pakistani physical therapy and health professional community would get benefit of all these important topics and up-to-date knowledge. Once again, I'm thankful to RIFA International University, as well as our international keynote speakers, as well as our audience who's attended the whole session patiently, like from 10 to 1:30 till now. So once again, thank you so much, everyone.
Thank you so much for your worthy words, Professor Dr. Ashfaq Ahmed Saab. Now, at the end, I would like to thank all the distinguished keynote speakers for their precious time and efforts Even with the limitation of the time differences and in the situation of the COVID, they have provided us with their time and efforts and the presentations. I would like to say thanks to the worthy chair and the co-chair of this session. And last not the least, our colleagues and all the participants. Thank you so much for joining this session. We will be back after 2 o'clock. We will have a prayer break now. Thank you so much. Jazakallah.